Good morning, everybody. Good morning, folks. My name is Shreese Pope, and on behalf of Better Health Together, welcome. It's always so wonderful to see all of you. As I was going around this morning chatting with everyone, we have partners who are in the room who have not been able to be in the room with us before. They've always participated remotely, so we're excited to have you and have you be part of the in-person learning cohort. So we are excited to have some local folks joining our presentation today and our training. I want to give a big thank you to Dr. John McCarthy, who is going to in the house. And Dr. McCarthy is not only on our BHT board, but he's also part of our Provider Champions Council, which I lovingly refer to as the CHAMPS. And he's going to be helping co-facilitate this afternoon. So we're thrilled to have Dr. McCarthy be willing to do that. We told him you guys are nice, so you might want to kind of perpetuate that for us. We're always happy, and I'm always amazed that Dr. Stock and Ann Shields continue to come back. Crazy, but they are good sports and wonderful people, so we're happy to have them continuing with us. I want to give just a quick thank you to Jason from Sunshine Terrace, who's going to be part of our panel this afternoon, as well as Christina Wager from Newport Hospital. Did I get that? Excellent. All right, thank you. So thank you to those folks. They're going to be helping us with our training and presentation today. I thought, it might be a little disappointing, but we thought we'd be a little controversial today and end around 12:30. So hoping that you go out and enjoy some sunshine. If you need to tell your bosses that we're keeping you till 5, I would be okay with that. So it's all for health, right? We need to be healthy and take care of ourselves. So always support that. I just want to follow up from a couple of things came up from the last meeting, and I just want to follow up with those. So we had some discussion with around 42 CFR at our last meeting, and so I reached out to the Department of Health after that. And I talked to Christy Spice, who's the Deputy Assistant Secretary for Policy. And the reason I wanted to speak with DOH was twofold. I always have like a little David Nielsen on my shoulder sometimes. I know, right? We need to do something about that. So having that discussion last month, kind of two things came out. One was that HCA is releasing guidance, and that's great, but when is that guidance going to be released? And number two, for me, whenever I've heard an agency or an organization saying that they're going to release something, that's good, but is there a follow-up? Is there someone that I can email or contact after I read that guidance and still have questions and still want some guidance? So what we got was I'm going to say two wins. The guidance was supposed to be released in the middle of April. It's not going to be released now until mid-May. That's the latest word on the street. But I did get them to agree that when they release it, there will be a person, an actual person, that we can email if you have questions. That felt like a good win. And then second, especially for our behavioral health partners, having kind of worked in that world for a little bit, for a few years, I think I picked up a little bit on the concern, so I hope I'm not out of bounds with this, that depending on who your licensure is or your licensure team coming to review you that day, they may say, yes, your releases of information are wonderful, no problems, and then 3 years go by, you have a second team, and things don't go well. And as you may recall, the Department of Behavioral Health and Rehabilitation's licensing team now falls under Department of Health. So they're all under one umbrella now. So I made the request, and they're going to do this, and I'm going to hold them to it, that after the new WACs are released this summer, that the licensing team either does a webinar or we're actually going to offer to bring them here to do a training about how are they going to interpret and support whole person care under Medicaid transformation. So we got that. That felt like a good win. In regards to the WAC changes this summer, I asked if our providers who would want to be a part of that or want to give feedback, if they could be involved, and yes. So I actually have several. I have Christie's, the Deputy Assistant Secretary for Policy. I've had her email address and phone number. And I also have Romero Cantu, the Director of the Office of Health Systems Oversight, who has agreed that even if you have questions currently, you can email him and he will answer. So there's the follow-up for the 42 CFR and part of our presentation last month. So at the, I know I feel tired right now. So we always ask you to do a survey at the end of the day. And astonishingly enough, I read every one of those surveys, as does our team and Dr. Stock and Ann. So we go through the results because we want to make sure that if we need to adjust, we can and do, and make sure that if you identify something, we'll see if we can adjust to that. So we had the question last month about what's the difference between EDI and pre-manage. There is actually a wonderful, wonderful, thanks to Kelly Miller, who's holding it up in the back of the room, there is actually a wonderful guide, and it's on HCA's website, that talks all about not only pre-manage, but also EDI. So that is free on HCA's website, and we will actually include that link when we send out the notes for that. Finally, before I move on to better and happier things maybe, so we always, interestingly enough, we get the feedback that, and this happens at the same meeting, we will get feedback saying the training was good, but it was too primary care focused. And then we'll get feedback that say, good training, decent training, okay training, but too behavioral health focused, right? So then that tells me that, well, maybe we hit the sweet spot in the middle. But when I see a lot of you and talk with a lot of you, especially at our Spokane Collaborative, and again, we have a lot of rural folks with us, but in our Spokane Collaborative, what I hear is, well, I don't speak the same language as primary care. I don't know what they're doing. I don't know what they're saying. Primary care says, well, I don't know what they mean by that. Their care management or care coordination is totally different than mine. I don't know what they do. This is your opportunity. That's all I'm going to say. Okay, this is your opportunity, please. So when I do my usual ask of please participate, please join in, please be a great participant, it comes back to this too. Our primary care friends are really nice. Our behavioral health friends are pretty nice. Again, you might want to invite them to, oh, Ed says no, right? Oh, no, all for it. There you go, Ed. Okay, I did want to make, as I make it down my list, so we have a couple of exciting things real quick coming up. Better Health Together found out this week that we are the recipients of an additional $50,000 grant from HCA for trauma-informed approaches, which is great. We've got a really short period of time in which to make this happen, and that's where my anxiety and stress and my eye twitch comes up. So it is wonderful that we got that, we received that, and we'll be able to offer some additional training opportunities and supports for our providers. So love it, love it, love it. My ask to you is that if you would like to give me feedback, if you would love to share your thoughts about trauma-informed approaches, please reach out to me today, email me. I would love to hear you. I would love to know what the community needs. I guessed, to be frankly honest. Didn't guess. I reached out to a few people, but kind of guessed a little bit. So I really need you folks, though, to help us make this really make this applicable to what you need in your organization and for the clients you serve. So if you're willing to join in on me, I would love to have you do that. Just let me know. And if I don't get volunteers, you always run the risk of just me calling or emailing or showing up at your office and saying, what should we do with this? So, and Anne's got her hand up.
Well, congratulations on your grant that you have to spend in 3 months.
I know.
Is there a target age group or population? No.
That's the beauty of this, is that we can be as wide as we can be. And when I submitted the RFA, because I had heard this. I've heard from primary care that they would love some training and support around identifying what is trauma in the folks that come into their setting, as well as maybe some tools around motivational interviewing for primary care, as well as our SDOH partners have also said those two things, that some of their folks aren't as trauma informed as they would like, and then if we can offer some tools to support them when they interact with folks, that would be wonderful. We also had the opportunity to support and reach out to some of our tribal partners too, who have always said that trauma-informed approaches would be very helpful in their community. So that's kind of the blanket I went with, but it is open and we can adjust depending on what you tell me you want.
What was that terminology again?
Trauma-informed approaches. Okay, there's a couple of community things that I want to share that I think you'll be interested in. And one is coming up next Tuesday. Our friends at Passages Family Support is hosting a peer town hall. So HCA Office of Consumer Partnerships is doing a 2019 Spokane Region Peer Town Hall. That's next Tuesday, April 30th. They are offering 2 sessions, one from 1 to 3:30, or the second from 5:30 to 8. I'm sorry. And we sent that out, so hopefully you saw that. Again, great opportunity for folks who might want to go and join and be a part of that. And then May 7th, we have an excellent opportunity, a community connected, addressing the opioid crisis together. And our Spokane Regional Health District has really been leading the charge on that with our task force, which we have a lot of members here that are part of that task force. That will be from 5 to 8 p.m. It's literally right next door at the Riverside. I know you guys love coming down here. I know you love parking and all the wonderfulness that exists. But they have a really incredible keynote speaker named Tony Hoffman, who is or was a professional BMX rider. So if you have maybe a younger population, that might be of real interest. And he really talks eloquently about his recovery and his struggles. So that will be an excellent opportunity. Everyone's welcome, and it is free of charge. So it's an excellent opportunity. And if you would like more information on that, we actually have I'm going to call you a founder, but we actually have Sarah from the Spokane Regional Opioid Task Force here who would, I'm sure, love to talk more about that. I'm behind time. So, okay, logistics. Security. You all had to go through security and wands as you came down this morning. But there might be 1 or 2 of you who have said this morning that you need to go plug your meters at 10:30. Sharice, I got to go plug my meter at 10:15. Thank you for sharing. We have 10 fobs, so the little security things upstairs in a bowl. So if you need to go plug your meter, you need to move your car, whatever you need to do, just grab a fob and you can come back in, okay? There is, in case you don't know, there's usually parking on this street down here, so not north, or not south, but north of the building here. And there's a lot just 1 block down that usually has space, and it's all day. So that's one option that people don't normally know of. And if you do that, you can actually, we have folks all the time, come to the door, we might let you in. But that's an option too if you need to move your car. I just ask if you have phones, please put them on mute so that we don't have to do the infamous eye roll and I'm not huffing and everything goes smoothly. And let me do one last check and make sure I've hit all of my things. And I think I have, and I've already put Dr. Stock behind time. So I've done my job. And now it's up to you to make, no, teasing, no. So we are just thrilled to have you. Really just ask that you just jump right in, participate, give us feedback, ask questions. Really, that's what we're here for. And these people are absolutely wonderful and experts. And so please use and abuse them. And with that, I'm going to hand it over to Dr. Stock.
Mic turned on? Okay.
Yeah.
Let's do a. Hear me in the back? No? Need. Okay, let's try that. Is that any better? Okay, testing, 1, 2, 3, 4. Okay, yeah, it sounds like I might be projecting in the back there. I also want to say hi to our folks on the phone and are watching us remotely. Just want to acknowledge you and hope that you all will participate as well today. We're going to have some exercises and do some work today because my expectation, I haven't done my job if you haven't walked out of here with some notes about what you want to do next. And for those who have already started this work, that maybe some ideas about how to improve on or to move forward in the coming years around chronic care management and how to think about that. So there we go. We're going to hopefully play some or develop some beautiful music today. I know there are a lot of conductors in here. There are a lot of experts that know their instruments really well, and hopefully together we'll create a symphony or a song or whatever that's going to be helpful. But what I really want to share with you this morning as a reflection to get started. This is my disclaimer slide. For those in the medical world, when you're giving presentations, there's usually a slide that says, I have no pharmaceutical connections, okay? So I'm telling you, I have no pharmaceutical connections for this talk or anything else. I also want to let you know that I'm not running for any public office. I may be the only person that's not running for public office, but I can tell you that I have a lot of opinions. And I have a lot of interest in this particular field. This has been something that chronic care has been something I've been interested in for my entire career of 30 plus years. So I have a lot of opinions about that. And I know that folks are coming, as Charisse mentioned, are coming with a different, looking at this work in a little different way and sometimes wearing a different lens. And let me tell you that the lens, I'm fully admit, I am a primary care physician. I'm a family physician, both in philosophy and in practice. I specialized in geriatric medicine and particularly vulnerable populations. And I have a bias toward looking at chronic care and how chronic care is managed. And I want you to know that and take that with as you hear me and listen to this, because much of this is coming out of the world that I lived in the last 20-some years. But we know that there are other groups here that are maybe looking at this in a little bit different way. And I just want to acknowledge this going forward, that this is a combination of both the folks who have contracted in January and folks that will be contracting in August. For many of the folks in the August cohort, some of the ideas around how you integrate chronic care management into your practices and your organization may be new, and or you may already have an idea of what you're going to be doing. But soon, in about a month or two, you're going to have to put it on paper. And I hope that as you walk out of here, you'll have a better idea about maybe how you're going to integrate that into your organization. For the January cohort, many, if not all of you, have already started this work. And I acknowledge, too, that many of you may have been doing this work for a decade or more. That there are some folks that have really are further down the road. What I would encourage the folks that have been doing this in January cohort is, number one, share your experiences. Share with other folks. And the other is to also think about, well, how can I refine what we're already doing? What's it going to look like in the next 2 years or 3 years? What do I need to prepare now? And to sort of look at it through that kind of a lens. I also know there are lots of folks from different disciplines in this room, and that you're looking at this. Charisse mentioned a lexicon about language. We all, as I mentioned before, we live on different planets, and we have a different language and maybe a different environment, and that we're looking at this topic through a different lens. For many of the primary care folks, they may have been looking through chronic care management through the MCO, the managed care world, because of requirements around how do you manage diabetes. Measures have been going on, they've been subject to measures for a long time. And then the integrated folks thinking about, well, how does this really integrate with behavioral health? How do you really make this work? I can say that for myself, I started practice 30 years ago. In the first 5 years, I did counseling in my practice until my partners said, you're not making enough, you're not doing, generating enough RVUs, generating enough business. I needed to stop doing that, because I was trained in doing that. And so ever since that time, I always had a license, an LCSW next to me. So to me, integrated care and having that as part of practicing primary care is core to me. I can't think of a philosophy of care, providing care, that's any different than that. So that is a lens that we all bring to this topic that may be different. Rural versus urban. The issues around how you deliver care in a rural area may be different, or will be different in a lot of ways than urban, just because of the resources. And I hope I will cover some work that's being done looking at that. I'll share that in the second talk later this morning. But definitely looking at this through urban versus rural lens, I think is important and needs to be acknowledged. And then finally, I know that there are folks in here that just take care of children or adolescents and families, versus adult. And there are different chronic conditions related to those two populations. So thinking again that looking at, we all bring a different lens, and what I would encourage you to do is to step out of your lens and step into somebody else's lens today, and to think about things that might be a little bit different for you. So why are you all here this morning? What brings us to this room? It's the health authorities' work and the BHT's chronic disease and prevention part of the plan. The aim that's written out there is to integrate health system and community approaches to improve chronic disease management. The populations, there are lots of populations that you could look at. BHT has at least early on, focused on diabetes, asthma in children, and chronic mental health disorders. And then there are outcome measures, the pay for performance measures that are tied to many of these. Some of these are being rolled out now, some will be rolled out next year, but these are some of the outcomes that the state will be looking at. So that really is what I think has brought everybody to this table today. So this is an old, so let's get into it a little bit. This is an old slide. This actually goes back maybe 20, 25 years for me, but I pulled it out because of the first quote. This was a description of what a chronic condition. This was, remember, maybe 20 years or so ago, we even had more of an acute care system than we do now. And so defining what a chronic condition is important. But there are three things about that one line that I think is important. One is that a chronic condition needs to be named. That you need to, that there are certain conditions that have a name to it. A chronic condition isn't just a chronic condition. There's diabetes, there's arthritis, there's asthma, etc. It has it limits what you can do. In other words, it affects your function, whether it's physical, emotional, spiritual, behavioral, mental, whatever, and that you may requires long, ongoing medical care. There is a medical component to this, and I just list a few there. The reality is, when you look at all the population, 8 in 10 of us will eventually have a chronic condition. of some sort or another, if we don't already. And it increases as we age. Past the age of 65, nearly 2/3 will have 2 or more chronic conditions. So this is just, it's common, and this is a big part of why we provide whole person care. Now, this is BHT. And this comes from, I believe, a couple of years ago during a survey. And have folks seen this slide before? I'm just curious. Raise your hand if you've seen this slide before. I shared it. Okay, there's 1, 2. Okay, 3. So I actually used this slide about last summer when I was talking about it, but this outlines a little bit about the Medicaid health status by county. So the blue, let's see if my pointer works here. The blue is the percentage of folks with one chronic disease. If you look at this, majority around between 25 and 30%. That's consistent with that previous slide nationally. If you look at this, probably the average age group is going to be younger in the Medicaid population. The orange, I'm kind of in your way there, aren't I? No. So the orange is the percent of folks with a mental health diagnosis. You can see that it's kind of variable amongst the counties, but still, again, pretty high incidence. Probably an average on there, maybe close to 1/4 to 1/3. The gray, this is a gray color, I believe, is the percent with a substance use disorder diagnosis. Again, some variable, but actually pretty consistent across all the counties. And then the yellow is with both, at least one chronic disease and percent with a mental health disorder or mental health diagnosis, excuse me, or a substance use disorder diagnosis. So that would be the yellow. So you can see it's a pretty common. Yes.
Are those additive? In other words, do you be in more than one category or not in this?
Well, you could be in the chronic disease category, and you could be in the yellow here too. So this is the percentage of folks that would be that have both a chronic disease and a mental health or behavioral health diagnosis. Okay. So this last week, I asked folks, and I'm going to do a shout out to my colleague at Providence Core, Lisa Angus and Sarah Bartleson and the folks there who have been working with the Washington Health Authority around data and management. Asked them to give me some data in terms of what are the top 10 chronic conditions in the BHT region, both in the Medicaid population, but then in the all payers database, and put them side by side. Has anybody seen this or anything like this before? No. Okay. So all payers includes Medicaid, all commercial, and Medicare Advantage, which is the managed care. Okay. Medicaid is just Medicaid. And so these are the top 10 diagnoses. What I'll say here is depression is all depression diagnoses, okay? Everything. Depressive disorders, on the other hand, is major depression 1 and 2, and also there are some codes in there that are also around screening. And other depressive episodes in there. And it's only this is a 2-year look back, okay? The depressive disorders, the data was only 1 year back, so it may actually be underreported in terms of that. So I'm going to just stop here and just have you take a peek at this for just a couple of minutes. And if you have any observations or comments, I'd be open to hearing this. Folks on the phone, hopefully you're able to see this slide also. Yes. It's ordered in terms of number of times coded. Yes.
Does all payers include Medicaid?
It does. It includes Medicaid. So it's Medicaid, commercial payers, and Medicare Advantage.
Just Advantage?
Mm-hmm.
Just Medicare?
Just Medicare Advantage. That's my understanding on somebody. Yes. What jumps out at you? Yes.
Well, I'm curious why asthma is in the Medicaid category, but it isn't in the all payers category.
Okay.
This kidney.
Right. And again, that's a good question. One of the things, it may be how it's coded. I mean, a lot of these are using claims-based, and the coding in the all payers in some systems may use COPD as opposed to asthma. There may be some other codes in there that is more prevalent, and I don't know. You'd have to dig down and look at that. Yeah. Anything else? Yes, John.
Behavioral health is a significant component of chronic care.
Exactly. Yes. Anything else? Yes.
What's the difference between number 6 and number 2 on the all payers?
Okay, so the depression is all depression encounters. Okay, it's everything. Okay, including, interestingly enough, it's also depressive episodes associated with bipolar. So you will also get those codes were included in there. In the depressive disorders, it's major depression 1 and 2, and another category called other depressive disorders. And then there's also a category in there around depression screening. So I'm not quite sure. I didn't really have time to kind of look in, but it kind of generates a lot of questions here about, well, what do you mean by that? Is it the people doing the PHQ-9s? Is there a code that they're using that's being counted in the screening or whatever around there? I don't know, but that's my understanding. Okay, so I'm just going to take a few minutes because I'm kind of running a little bit. We're going to try to make up some time here because I really want you guys to do some work today. But I pulled some slides, and again, my colleague Lisa Angus and folks helped pull some data around some particular data that I thought you might be interested in seeing. And I apologize if you've already seen this before, but these are the first three. You can't talk about chronic disease without talking about smoking. And so just want to look at here, looking at the BHT rate versus statewide rate. Let me just sort of mention, because I know the question is going to come up, is why do Ferry and Pend Oreille have no color associated with them? Pardon? They don't smoke there. Yeah, maybe. You tell me. I'm going to have to go up there. Apparently that's for confidentiality reasons. And I suspect that it's because the numbers are so low. And so they did not report that data. The hash mark is sort of the one step up from that. It says the data is not as reliable because the numbers are small, but still enough to put out there as a number, as data. So this gives you a little bit idea where BHT is at. You also can't talk about this unless about chronic disease without talking about obesity also, in my opinion. So again, looking at where BHT is versus the state, I'm going to move through these pretty quickly, and you can go back and look at them. The slides will be available. You can feel free to contact me if you have, or Lisa, if you have questions or you want to have more. We hope to actually bring a measurement learning collaborative or a learning cohort piece to this sometime this year, and I think that this could easily be part of that. Then I thought this was a very interesting question. Yes? No, I don't think so. I don't think it includes vaping, but maybe somebody else knows that. But
Also, having come from a rural area, smokeless tobacco is much more common in those rural areas than smoking is, and that would be a good
yes.
measure.
Yeah. asking about tobacco use as opposed to smoking and a lot of this is kind of depending on how you phrase the questions. Okay, and then obesity. And then poor mental health in the last 30 days. I thought this was a very interesting question. This came from the Burfus data. Adults ages 18 and older who answered 14 or more days in response to this question. Now, thinking about your mental health, which includes stress, depression, and problems with emotions, for how many days during the past 30 days was your mental health not good? So this was the percentage of folks that reported that 14 or more days were bad. Okay? Yes?
Quick question on the legend. Is the separation of the colors in order to evenly distribute them amongst the categories, or is there some sort of reason for the breakout percentages that is used?
Yeah, I'm looking at the numbers. They're pretty specific, aren't they? Pretty specific numbers. I am not sure. I guess my thought that this was. I don't know the answer to that question. You have to look and see. Yeah, it's a good question. I wanted to just share with you a little bit about all-cause ED visits. Again, we're trying to impact ED visits and hospitalizations. That's kind of the cash cow. It's the piece that brings cost to everything. And just share a couple of things, a couple of slides about that in terms of ED visits. Looking at BHT rate versus the statewide rate. This is for all causes. These are discharges from the ED, including mental health and substance use. And then hospital utilization. BHT is a little bit higher in the ED side, a little bit lower on average in the hospital utilization side. These are discharges per thousand. And then I asked them to look at diabetes-related hospitalizations. These are related to hospitalizations in diabetics that were related to a diabetes-related diagnosis. It looks like the BHT rate is a little bit higher than the statewide rate. And then I asked them a question about asthma-related hospitalizations. Again, asthma, BHT is a little bit higher than in terms of hospitalizations than, and these are all payers. This came from the all payer, as opposed to just the Medicaid only. Okay, should probably. Okay. So what are we going to do about it? I've got a couple of definitions in terms of chronic care management. This is the one from the Institute of Medicine, now known as the National Academy of Science. An integrated care approach to managing illness, which includes screenings, checkups, monitoring and coordinating treatment, and patient education. Improve quality of life while reducing your health care costs if you have a chronic disease by preventing or minimizing the effects of the disease. Okay, this is the sort of the IOM or NAS. This is the other definition from Ed Wagner at Group Health. It's a fancy checklist of things that the literature states we need to change care. This was a quote from him when the rollout of the chronic care model. Ed and the folks there and nationally, back in 1995, released the chronic care model. So I'm going to spend just a very quick little bit of time describing the chronic care model, since this is the model in which folks are being asked to use. It's been around for quite a while. What I would say, I think for Ann and I, that goes back to maybe 1997. Yours might be before 95 and releasing 95, 97 when they started doing improvements around with diabetes care using this model. They tried to do it in geriatrics. They stopped doing it after 1 year. That's a whole different discussion. The chronic care model has historically been focused on a single diagnosis, like diabetes, like asthma, like heart failure, like depression, okay, where you apply the model to a particular chronic medical condition. What this large bladder-like diagram, I always like to tell people to start at the bottom. really the bottom line here is that we want to improve outcomes, whatever outcomes you choose to improve in diabetes or asthma care or whatever. But that's really what we're shooting for. And in order to make that happen, you need to have a productive interaction between an informed patient and activated, not just informed. You can know about what hypertension is or what diabetes is, but if you're not activated to check your blood sugars 3 times, 4 times a week, you're not activated to know what you can eat and what you can't eat, then you're not going to get the outcomes that you're going to want to have. And you need a prepared, proactive practice team that's been prepared to help them with that, either through motivational interviewing or through various trainings to get them activated, get them informed. You need staff to know the right medicines to prescribe for their diabetes or medical conditions, so on. So you have to have this. And in order to have this interaction, you need a system in place to support it, okay? And so certainly these have been divided into buckets that are sort of what we're calling the key elements. A self-management support. What do you have to help patients and clients become more informed and activated? Do you have a delivery system design? Do you have the right clinicians who are connecting with the patients at the right time over the right issue? Is there a system in place that makes it? I like the one thing about delivery system design is a lot of this is about access and access to care when people need it. And do you have a system in place that makes that happen? Do you have the decision support? Do you have the guidelines? Does your staff know what the guidelines are that's best care? Do you have a specialist that you can contact, you can pick up the phone? In my practice, I had a psychiatrist who I would pick up the phone and I'd call, and he'd wherever he was, if he would pick up the phone or he'd come talk to me because we had worked out a deal where he knew that I was caring for some complicated, vulnerable folks, and that time was an important thing. So we had a sort of a deal worked out around that. But what's your contact? What's your hotline for decision support? What process do you have in place for that? Clinical information systems. A lot of this is about having a medical record that you can access, others can access, registries, et cetera. And then all of this has to exist sort of in a healthcare organization. Your practice, your organization, your health system, whether it's Providence or Multicare or Chaz or whoever, how does your organization support all of these? And then that exists within within the community, like BHT, like the folks in your particular community. So this is the chronic care model. Now, one of the things that the chronic care model didn't address early on, but actually later on started addressing, was the community policies part. The importance of having policies in your community where you can't smoke in public. How about policies in your community around not having sugared drinks in schools? What about all of having gardens and places for people to ride bikes? And what reminds me here about this is the community benefit and the importance of the community benefit, particularly with this ACA. It's no longer new. With the ACA, and how are you leveraging those community benefit dollars to address some of the community policies that really impact how they manage their diabetes? Okay. The other area that I think was sort of left out in the original was around patient safety and the importance that we need to make it safe. We know that we were making mistakes a couple of decades ago. We still make mistakes, but we didn't have a system for identifying and then following up with them. And so that's part of the organization. That's part of your organization to look at patient safety in terms of that. And then care management or care coordination was really not originally, I think maybe more implied, again, that's my personal opinion, but not really called out, that you have a proactive set of activities that really focus on preventing people from heading into the emergency department. The other is the case management. A lot of you have been participating with Ann and John around caseload management using a registry in bidirectional care. And that's a part of what you design into your delivery system. And then cultural competence. I think that's the other piece that was not originally there and is present. So I added two more that I think is that I've not seen any, and maybe Ann, you know, but looking at the chronic care model through an equity lens. And I think the other is looking at the social determinants and adding the social determinants to the chronic care. Ann, do you have anything you want to add to this? I'm just going to call you out. I warned you ahead of time. So, you know, one of the things that I did here, and you can comment on the chronic care model because you have a lot of experience with this as well, but I know that folks, there was some angst, at least I sort of suspected there was some angst around where does the chronic care model fit into bidirectional care? What's the overlap? So I put together a crosswalk showing you sort of the elements of the chronic care model, and then looking at the BRIE standards and the collaborative care model core principles, and where they sort of crosswalk and address that. And what I would say just in general is that the work that you're doing in bidirectional care for the most part covers all of the areas, or many of the areas of the chronic care model. Short of what I would say maybe focusing on a medical condition. I would say that. And then the other kind of the area that I think sort of jumps out for me is sort of mobilizing community resources in terms of that being a part of the chronic care model that I think is really important is how do you connect to the community. So, Ann, you want to just?
I'll just add that, well, you know, that term model gets us into trouble, right? We got a model for this, that, and everything. Just to be clear, what people think of as the collaborative care model was really based on chronic care management. It really came out of that. So none of these things are separate siloed threads. So I have a big voice. It's okay.
There you go.
So anyway, I just wanted to make that point. If there's any confusion in the room, it's a great day to sort that out. But absolutely, you can't go wrong whether or not you're looking towards the BRIE standards, which are not only written into our state multi-payer strategy, but they're also in your MCO contracts. So good things to keep in mind. I think that's about it.
Okay.
I think of collaborative care, and I'm probably the only one of the few people that work for both Ed Wagner as well as Wayne Payton and Jürgen Munitzer. What we think we've added with collaborative care around behavioral health strategies is the concept of treatment to target. Treatment to target. Overcoming clinical inertia, which is the goal of all of these more planful systems of care.
Great. Any questions about that? I mean, I think this is actually a very important thing. I can probably skip many of the other things and we can go on to the panel. But I do think there's been some kind of confusion about where this all fits together. And I'll also ask people on the phone or out more remotely if they have any questions also about this, because I don't really want to. This is our opportunity to make sure you all are getting this. Yeah. Okay. Anybody on the phone, Sarah? Okay. All right. So thanks, Ann. So I threw this slide in. This is from the survey that you all did before before you wrote your plans first time around. And this just looked at, there were some questions around the chronic care model elements and the percentages of organizations in BHT at that time. You'll see there are a lot more organizations than actually organizations that are participating. That's because there were folks that chose not to participate. But it just gives you sort of an idea, and I think the thing that sort of jumps out for me is that the folks here that have been are both in primary care and behavioral health are likely have already had exposure to the chronic care model and have been implementing some of these elements already. And I think that's probably why you're seeing that difference. So interventions that work. I'm going to really, this is just the last couple of slides. So just to highlight a couple of things that what we think that the literature is telling us this works. We actually probably have a decade or two. I mentioned before, a lot of these things have been going on and happening. We've known that they've been working for a long time. We haven't been able to scale it. We haven't been able to bring it up to get people to do it, and that's what we're intending to do here. Having a medical home, having somebody with diabetes or asthma or whatever, having a source of their care is important. And the patient-centered medical home work, whether it's NCQA or your own state certifications around that, is important. Folks, that seems to work, particularly when they're integrated and integrated settings. Care coordination or care management services, which is really a set of services that really reduce harm, reduce utilization, and improves the outcomes of individuals in your practice, works. The teamness, the culture, we might do some more of that later this year, but that's also, there's evidence that makes a difference. The registries and the work that you've been doing with, many of you have been doing with Anne and the folks at Ames around the caseload registries, as opposed to treatment to target based on the information that you get around that is extremely important, and we know works. On the other hand, there is also the population-based part of registries, where you have a diabetes registry of all the diabetics in your practice. Are they all? Can you actually keep track of how often they're coming in? Have they had their hemoglobin A1Cs? Have they had a PHQ-9? Because they all need to be screened for depression. There are sort of standards of care that are essential, and a registry can be a tool to help you manage that population. And then the quality data management sharing with your staff and patients. I think maybe we've mentioned before is how many of you have in your breakout room all the pay for performance or the performance measures and how your clinic is doing compared to everyone else. That should be transparent to your staff. You'll have much greater engagement. How about sharing it with their patients? How many of your folks in your practices know that you're participating in something like this? I can tell you as a patient, I would be sort of enthused to know that you're participating in something like this. And so what are your outcomes? What are the things that you're working on that are important? Health system and community engagement, we're going to talk some more about that, but collaborating with community organizations, we know it works. One thing that we know is that when you attach money to things, that behaviors change. We keep learning that over and over and over again. Sometimes we listen. And incentivizing that, whether it's a staff person or a clinician or an organization, that people get off the seat and do change their behaviors. Transitions of care is really a basic thing. The most dangerous time for vulnerable populations is when they move from the hospital to home, or hospital and nursing home, or from one facility to the next, or home to a skilled nursing facility. Those transitions of care are absolutely critical. And we hope to bring, before the end of the year, actually some work around transitions of care going forward, because that's really critical. The only thing I just say, workforce capacity, there are a number of ways. I know that's something that in areas like here that you, particularly in rural areas, that you struggle with getting the behavioral health specialists in these communities. I put Project ECHO up there in part because I have a deep interest in this and working with telementoring. But again, you can, and a good example of this is that you can get clinicians buprenorphine wavered, but will they prescribe? And one of the issues that we've seen over and over again, at least in the state where I live, is that we have all of these prescribers, but only 25% of them actually prescribe. And that what they need is an ongoing support from an expert team. And so we've done this through Project ECHO, where they can provide some standards but from an addictions medicine team on a weekly basis, and then they can bring their cases, and in that way begin to support them and to give them the confidence that they can actually prescribe. But Project ECHO can be a way in which you can leverage some of the things that you really want to get done that people aren't getting done as a way to move forward. We're going to talk, these are some other interventions that work around chronic disease for patients and families, patient and family advisory councils. We're going to talk more about that later. And then these identified specific strategies that are related to chronic care management. The two I want to point out to, most folks know about the Stanford Chronic Disease, CDSMP programs, but I also, the diabetes prevention program also. Having read all of the transformation plans, I can only think of a couple of folks that, or less than a handful of folks that mention that. And then also the paramedicine models are very intriguing, particularly in rural areas. So I'm going to ask, Jay, we're going to move forward. And I asked 3 of your colleagues in the community to come and talk a little bit about what they're doing in their own organization and to share a little bit about that. So John and Jason and Christina Wager, very appreciative of them coming forward to share a bit about their organization. So the first question, I'm going to ask them to introduce themselves and to tell you a little bit about their position in their organization. But really the question for them is, what does successful chronic care look like in your organization? And maybe if you could give a specific example of something where you felt has been successful and proud of this is kind of worked. John, why don't I start with you?
Sure. So I'm John McCarthy, and I work at the Native Project. I also work for the University of Washington School of Medicine. And for my rural colleagues out there, I'm the rural dean for the School of Medicine, and I have a great appreciation for those of you who are not in the room. So one of the things that we're able to do, we're effectively an FQHC, and we have care coordinators and behavioralists that are immediately available at any point. So I'm done with my visit, and the patient has some mental health issues. I can call them into the room, and they'll take care of things that I'm not as skilled at, nor do I have the time for. So I have a master's in counseling psychology before I entered medicine, and like Ron said, I don't have the time to do that component of care. Likewise, as you all know, social determinants of health make a significant difference in terms of our patients' health and mental health. And so if somebody's homeless or they don't have food or they need a bus pass, I can call in my care coordinator and say, look, they're having trouble getting to their urology appointment, and we need to figure out how to make that work for them. So in terms of their ongoing health, I have somebody outside of myself that's really dealing with the critical issues that they have to deal with. I can tell them how much insulin to use or make some minor adjustments, but I firmly believe that social determinants of health are really what make a difference for my patients and your clients or patients. And so how do we operationalize those resources for those patients? I'm in a good situation. I had a colleague on Tuesday, the last day I was in the clinic, and he said, oh my God, I don't know how I'd work in a place that didn't have these resources available. And I've worked in places that I haven't had those resources available, and it's very difficult. So again, as I look to my rural colleagues and say, how do you play this out? You don't live in an area necessarily that has that access. And my urban colleagues know how long it can take to get into some of the resources that we want them to be able to achieve. So bottom line, I'm in a good situation. I think that's the kind of care model that we want to move towards. I think there has to be the financial incentive to get us there, and fortunately I'm in an environment that allows that incentive to exist.
My name is Jason Barnard. I'm the project manager for Sunshine Terrace Sunshine Health Facilities, and my company had the foresight in putting someone with a background in social work into a project management position, because this is the direction that healthcare and behavioral health is moving into, is someone who has that clinical background, that social work background, who can come together and take a look at what's going to be best for our clients and drive that model. So Sunshine Terrace is a long-term care assisted living facility with a behavioral health mental health agency. As we know, people who are living in assisted living facilities, their care is often fragmented and uncoordinated, which has resulted in transfers from primary care providers, hospitals, emergency rooms, urgent cares, specialists. These people are being moved around to a great physical and emotional burden to themselves. So what we did is, at Sunshine Terrace, which is an assisted living facility, we took a look at what we were doing at our nursing home. And in our nursing home, they have a program through United Healthcare, through Optum, which is much like an Evercare model, where they have an AR&P on site who is seeing the residents and clients there, who's there 4 to 5 days a week, working with the nurses, the CNAs, the social workers, their primary care providers. And we asked ourselves, is this something we can do at our assisted living facility? So we found out, yes, Optum is going to let us do that at our assisted living facility, which is going to be great, because what we found out is, yes, since we have a nurse on site, we have a transportation coordinator, we would send our folks to their primary care provider or their specialist, but we might not get any information back. Or their primary care specialist isn't working with their heart doctor or their eye doctor or even their dentist. And we really wanted to create a model and have someone who was that primary contact there at our facility who could work with the entire team who was coordinating everybody. So that is really the direction that we're heading. The AR&P is going to work with our clinicians and our behavioral health specialists to make sure that the PHQ-9 is done monthly, that the DAS-10 is done monthly, that our CNAs are doing monthly vitals such as weights, such as hypertension for blood pressures. So we're really trying to hit areas in both the primary side and the behavioral health side. One of our goals was to, again, reduce the fragmentation of care, but also we believe we're going to be able to have a 45% reduction in hospitalizations and a 50% reduction in emergency room visits by having that AR&P on site who is going to be able to provide the education and manage these chronic diseases in their home setting, rather than having to send folks out to the urgent cares or out to the hospitals. We really want to help our folks receive their care in their home setting.
My name is Christina Wager. I'm the Director of Operations at Newport Hospital and Health Services. Newport's about 45-50 minutes north of here, and we are in a rural community. And one of the things that if any of you work in a rural community, we pretty much have to be self-reliant, which is a little tricky because we don't have all of the resources that a metropolitan or urban area might have. So we have to wear multiple hats, which means that we might not be exactly the expert on these things, but yet somehow we have to become experts. And so we do rely upon Better Health Together and Empire Health Foundation and any resource that we can find that would be able to help our people, our employees, to be able to provide the care that we want to do. And so I just really quickly, and I'm sorry I'm not going to be able to see the people on the phone, but how many of you in here are doing some type of chronic care management? Are you guys doing it? How many of you feel like you're experts at it? Nobody? What? Anybody here? No? No? Even us?
Yeah, pretty good, yeah.
Oh, okay.
Oh, I'm sitting up here.
Jason's the expert.
No.
I don't feel like an expert, although we definitely try to move forward. How do you help? Our big thing is, how do we help our nurses who maybe 6 months ago were doing nursing in an acute care environment? So now all of a sudden they're doing chronic care management. They're going to look at us like, I have no idea what to do. So I think that the elements that you see in front of you, the elements of this chronic care model, are extremely important. I'm going to talk about some of the things that we've done in some of these elements to help provide a structure or a framework for those people so that they can help the patients in the way that we want them to be helped and that they themselves want to do and help. So one of the other factors in all of this is that we've got 10 primary care providers, and they're all very independent. They're very independent, and they like to deliver their care in a certain way. So they have 10 different ideas of how this should be done. So I don't have the resources to be able to provide chronic care management in 10 different ways. So we agreed upon a basic framework that allows us to modify the care based on provider wishes, but also with the patient involvement, and that's extremely important. Obviously, the providers have a great understanding. That's the primary relationship. It's the patient and the provider, and we need to take both of those things into account. So our framework helps to provide some direction for those care coordinators that maybe have not done this before. These nurses are not case managers. They've never done any work like this. So we provide them with probably more education and training that they ever thought that they would take in things like motivational interviewing, patient activation measures. Have any of you used the PAM, the marvelous program? That's all social determinants of health. That's all things about, hi patient, we understand what your chronic conditions are because they're coded somewhere in this magical EMR of ours. Great. But what does that mean to them? And how are they going to be able to participate in their own self-management? That's the word that's used here. Are they really going to be able to just go, oh, yeah, I got it. Thanks for all the assistance. That's not always the case. We need to understand each patient individually. And so we're asking things like, again, in the palliative care world, asking 7 questions. So what are your hopes? What are your fears? What are your family relationships like? What kind of support do you have? Do you really understand your own conditions? Do you understand what it really means? And so if we don't have a good grasp of all of that information, we're not really going to be able to help the patient at that very base level. So our framework is really defined by identification of patients. So we talked about many different ways to identify them, using population health, using registries. But honestly, when I give a list of patients to a provider, they kind of start getting glazed over eyeballs. And so how do we start to target that a little bit? So we do some of these questions at annual wellness visits or physicals. That's one way we can get some more information. We target patients that are in the hospital. So those patients with chronic conditions, we're asking them these questions. And we're getting those questions over to the providers and the care coordinators. We make sure that we reach out to the patients and we say, we saw this answer on these questions, and we want to check into that a little bit and see if we can provide you with any help. We don't know what kind of help yet, because again, we've got to dig into things a little bit. So we do some of these assessments. Again, 7 questions: hope, environment, relationships, the patient activation measures. What else can we assess? Can we go out into the patient's homes? Sometimes they'll let us, sometimes they won't. Unless you get the right people to go in their homes. A lot of these patients come into the hospital regularly, so maybe those EMTs that they're pretty comfortable with going into the homes, maybe they'll go in. Maybe they'll have no problem with those people going in. And so what do their houses look like? What kind of food are they eating? Do they have CHF and they love potato chips? That could be a problem. Do they understand how important it is to weigh themselves frequently so they can kind of head it off at the pass? And then again, if the patients are willing to accept our help, we need to create a care plan. And again, that's not just a bunch of nurses saying this is what we think you should do. It's really talking to the patient, talking to the provider, and creating really goals that are manageable, that might not be the highest level, but you know, okay to exercise, walk around your living room a few times. Just get up and get moving. So make it manageable for them. We have to make sure to communicate all of this information back to the PCPs on a regular basis. Because again, they're the ones that are, again, remember that relationship is the most important to the patient. And so how is all of this really working? We've got to follow up, right? So again, we have all of that going on where we have phone calls happening. If we can get into the homes again, that's wonderful. We're using as many resources as we can get. So we have health homes going into homes for some of our high-risk Medicaid clients. We have our EMTs in our community going into homes for those high utilizers of the ER. We're doing everything and using everybody that we can. Matter of fact, as a side note, Jason's mom is one of our MSWs, and she's awesome. So there's nobody, I think, with more energy in our building than Diana, his mother. She runs around like an Energizer bunny, thank goodness. So documentation, figuring out where... Yeah. If you're a chip off that block, then you rock. Yep. Documentation, making sure that you're putting things where people can find them and that we can make sure to get that continuity of care. So these are the operational things. Again, all of this stuff is great, but how do you turn it into something that you can practically do in your facility is one of the most important things. And all of us are unique, but all of us are the same too. So.
Great. Thank you. So let me just open it up to the group here. Questions for John, Jason, and Christina about what they've been doing, and any thoughts about how you might do it in your own organization? Or?
So, United Healthcare is funding your ARN position?
Yes, they are.
So the question was, is United Healthcare paying for Evercare?
Yes, they are. And in fact, so what we did is we took a look at our Medicaid population and we realized 2/3 to 3/4 of these people are actually Medicare A and B eligible as well. And so when we were talking with Optum and United Healthcare, they said, yes, we'll pay for that ARNP position, and we'll also pay your facility additional money as well to have our, to utilize your space, basically.
So if I could, one of the things I get is ARNP reports back to me on my patients, and I get all kinds of information on my patients. And because there's so much of it, it's overload. I can't utilize it. I can't read through and say what's important. So what? You gave me an A1C. I just did one yesterday. I know exactly what I'm doing with it. So we need to integrate that new information that's coming in, and we need to separate the wheat from the chaff, because if there's information overload, I as a physician, I look at that very briefly and file it, and I don't operationalize anything off of it, and that's probably 95% of the time. And you know, I see you out there, Rachel. I don't know if that's your experience, and so she's nodding her head yes for those of you on the phone who are my rural friends. But we have to figure out how to get this information in a way that's meaningful. Information by itself is not meaningful the majority of the time.
I'd like to say that for organizations that are really preparing to get ready is take a look at your electronic health record. You don't want to be halfway into this and realize your EHR is not going to be able to meet your needs to really integrate and to manage chronic diseases, because you're going to be out thousands of dollars, and there's a bunch of time that takes to implementing a new electronic health record.
We're going to move and do some work. And before we do that, we need to give these folks a hand, because of what they're sharing with us. Thank you. And I'm sure that they are available for any other questions. If there are some details around that, grab them and get as much as you can from them. They're also going to be joining in the small groups. So we're going to move forward to a guided discussion. And the intent here is to get you to begin to look at each of the elements and to put down on paper ideas that you have that you think you could do in your own organization. So my expectation, you're not going to be handing anything in, but my expectation is you'll be walking out of here with some notes about that. So what we thought we'd do is, for this next part, is that we're going to divide the group into the behavioral health organizations will stay in this room. The primary care folks are going to go across the hallway to the room next door. And the folks that are in the integrated care organizations already, you're going to decide on your own which group you're going to be part of. What we're going to do is, and this will be sort of a guided discussion over the next hour or so, or probably less. Then we will have you go through each of the elements. We're going to actually have you start thinking about, first a task would be think about your targeted population. Who are you targeting, okay? And there will be then a short discussion. But then for each of the elements, each of you will reflect for 1 minute, jot down some ideas for that particular element. You'll then pick a partner or two partners and have a brief discussion for about 3 to 5 minutes of what you wrote down. And then we'll open it up to the group to share to the larger group, have a brief discussion for maybe 5 minutes at most. And we'll go down through the elements and do that in both groups. And our panelists are going to join us. And then we'll all come back in about an hour, and we'll just do a 15-minute debrief as a larger group, get your reflections and thoughts about what you learned in the discussion. Any questions about that? Did I miss anything, Sarah, Charisse? And yeah, at some point you'll get fed. Ann Shields is going to facilitate the group across the hallway in the primary care group. So anybody have any questions about what to do? Okay, let's do it. Oh, before you go, so this is everybody should have what I call a driver diagram, and this is your worksheet. So it lists the aim, and a driver diagram lists the primary drivers or the elements of the chronic care model. The secondary drivers are kind of the next level up. What are the things that actually drive that particular element? And then their change idea is what you can do in your clinic or your practice or organization to address that. So this is a worksheet that you can use to jot down ideas during the discussion, okay? And everybody should have one of those with their packet. Okay. But I want you to go ahead and think about your targeted population for behavioral health. What is your target? Who's your target?
example, some of the targeted populations for you, like population being exposed to for us, we already have that. We can and we have risk. I don't know if that's good or bad. I don't know if that was confident or not. No, I can't tell any difference.
So you guys look at like a table that's all talking together, and the goal was to go into twos first, and maybe for Oregon, that's fine with me. But the goal was to do kind of dyads, talking about things, and then break it into the six, and all come back together.
Not this table. I'm just going to, what have you decided? Anybody wants to share about what their targeted population is going to be?
Yeah. I can share a little bit about what we discussed previously and we're looking at is, you know, we serve a lot of individuals with adults with serious mental illness. And we know that there's a great many of them that also have comorbid diabetes, as well as hypertension, other chronic illnesses. So what we're looking at is how do we, and you and I are just talking about this, how do we not get into an overload mode where we're identifying, we say every individual in our organization who has a serious mental illness and has a comorbid chronic condition, we've just identified probably 8,000 people in our organization. And then how do we also not get too greedy, and this is to your comments, Dr. and say, well, here's all the analytics, here's all the information, here's all the data, and now let's start, giving it to our providers. It's going to be a recipe for nothing happening because everybody's going to be completely overwhelmed.
Deer in headlights.
Exactly. And so how do we find some bite-sized pieces and maybe identify very specific population? And what we're thinking, we're not this idea, there might be, for instance, individuals with, say, schizophrenia and comorbid diabetes. Mm-hmm. And this would be the kind of thing we'd have to come to agreement on with our physical health care partners. And how do we really identify then what are the metrics we're going to look at? And how do we assist our care providers, and this also gets to your comments, Dr. McCarthy, in not expending their valuable time doing things that somebody else is in a position to do capably. So in our organization, we've begun to utilize, and we're very much in a piloting stage, the role of care navigators. Mm-hmm. And these care navigators in our world are folks who are non-credentialed, meaning they don't have an active academic degree, but they're trained in things like motivational interviewing. They have experience in our organization working with our clients. Actually, our recruiting pool is our customer service reps. The people that encounter these folks are our clients on a daily basis. They know our clientele. They're passionate about helping them. They know how to connect them to resources. And we've created several positions where those folks are moving into a role where they're assisting in essentially being the connectors and the communicators. And in the future, we hope that they'll be, and we envision that they'll be ones who are working off of a patient registry with the sort of information that they're not going to get overwhelmed with, and they can assist in sort of being, I call it sort of the glue that helps connect the work that's going on the behavioral health side, on the physical health side. Because one of the things I've shared with our physical health care partners, we know that on any given day, we have dozens and dozens and dozens of individuals in our care receiving, whether it's medication management, case management, counseling, who are literally dying from a chronic condition, and we don't know it. And that's where we're at thus far. We don't even know barely what patients we're sharing, let alone what chronic conditions, let alone if that's being treated. So we've got a lot of opportunities. The challenge, again, will be how do we take those first steps and just not find ourselves overwhelming, our workers.
Great, thanks, Jeff. So schizophrenia with diabetes could potentially be one of those. What I would say is that when we begin to focus like that, you create a program that really works. You find out a lot, it becomes generalizable. You can then start adding other things, and you learn more and more about that. So another. What other table? How about this table here? How about you guys?
Well, we're Educational Service District 101, Northeast Washington, and we are venturing into behavioral health, pursuing licensure. But one of our questions was, is autism a chronic condition? And if it is, then how does that fit into the care model? And my mental health therapist, who's here with me, one of my mental health therapists mentioned that we're a fairly resource-poor region for supports for families who have students on the spectrum, children on the spectrum. So it's this.
So what I would challenge you to is so as Ed Wagner says, it's a fancy checklist, okay? Use it as a checklist. It's not a model necessarily. It's not a guide, It's something that you need to go through. Okay, well, how well are the families in terms of their own knowledge and activation around managing that with the child with autism? So you begin to ask the questions and going down the list, and that's but you have to start. What I'm getting folks to start thinking about is what's the population you want to start with, or where you want to begin to focus. How about this group over here? Yeah.
So our target population would be those who are 18 years of age or older who have a diagnosis of PTSD and an ACEs score above 6 who are on psychotropic medications.
Great. That's being very, very specific, but I would get into, particularly if you have a broad range of age groups in your organization, be specific about what age. Are you talking about children or adolescents? Are you talking about 18 and older? Are you talking about, be specific about the population you want to impact and start that way. Okay, well, we're going to move forward, and this was really helpful, and we can talk more maybe during question and answers about this, but I think that, as you can see, targeting the population is really important because that's going to really determine what are the things, some of them may be kind of small, but what are the things that you could be doing with these elements that would impact that. So let's start with the delivery system design. So I want you to just take on your own, just jot down some things that you think you could do in your organization to impact that particular element. That's 60 seconds and counting.
Right. Well, I totally teach you well. That's something. I think it's just a question of doing it. And these are all two-story checking. We do a check out. I get it. I think if we just at least show that we take some damage from the that's what you're doing. That's your doctor. Into an anti-speak gun. She was turning in the application. I wrote her and I said, this is good, but this part here, no. And then I went into about, 2 or 3 suggestions. But as far as MT, I said, sure. You have to, they are combined. I don't, in other words, you can do that, but I don't think it's going to matter. I've tried. I've told you.
Let's get a little bit of a report out on what you talked about. And I'm going to start up here in the front table. And who wants to? Okay. let me get people's attention first so that you can share. Hello. Hello. Good. All right. Now this is the part where we're going to share with everybody else, including the people on the phone. I'm going to call out. We'll find out so I'm hoping that you're also having these discussions. So, yes?
So one of the things that we identified and talked about is, I guess, related to care compacts and bidirectional care. We have a pretty good initiative in our community where providers are communicating back and forth on a personal level. They'll see each other, they'll talk about patients, they'll meet each other in the ED, but we don't have a formalized workflow process where mental health counselors are reporting, communicating with the primary care, and they're getting reports back from that process. So that we're all understanding what each others are doing and how our efforts are impacting each other and coordinating that care for the benefit of the patient. So I think that the idea that the care compacts that we're working on, I think will help to streamline that and to help us develop those relationships so that our siloed providers become unsiloed through a formalized system where we're sharing and communicating information.
Yeah, great. And that might look a little bit different depending on which group you're interacting with, but it's one way to begin to standardize and to create a message to the rest of your staff. Okay, this is how we do it here, and that's how they do it in the other office, and some agreements around the sort of the delivery system design, if you will. How about this group here?
No, you guys. Go for it. You guys go for it.
I heard your ideas. Go for it. Great, we have some ideas.
Okay.
All right. Nobody wants to take credit for the good ideas.
Our target population is co-occurring adolescent girls, ages 12 to 17 in our inpatient facility. And what we're looking at is how to set up a care coordination team to make sure that as they move along in our program, that they're being tracked on a weekly basis to make sure that we can see improvement in that co-occurring section. And then a couple ideas that we're trying to start to kind of develop is what happens when they leave. Because that really seems to be where one of our biggest gaps are, especially our girls who come to us from all over the state. How do we ensure that they're getting their physical and co-occurring needs once they leave our facility? So we're starting to kind of really brainstorm around what that's going to look like and what that care team's going to enable, and have us be able to make sure they're going to their appointments and have a bond with whoever that navigator is. So just starting the idea process on that.
Great. Yes.
Oh, yeah. Yeah. I'm Sarah Spear, and I'm with Daybreak Youth Services.
Great. Thanks. So how about somebody out remotely on the phone? Somebody can, your mic is live. You're turned on out there. We can't see you, but we know you're there. Who wants to share? Any thoughts? And I like the idea of when you do provide a comment and talk about this, let us know who your targeted population is and who you are. That's very helpful. It should all make sense. It's contextual. Anybody out there? Hello?
This is Jennifer from Lincoln Hospital.
Yay, Jennifer.
Hi there.
Hi.
I think Ed spoke well to what we are working on within our county in terms of the care compact and looking at our mental health patients with chronic disease.
And have you have a target population you're going to work with?
Our mental health patients with chronic disease, given that we're rural, our volume isn't as high, so we feel like that's a reasonable population to look at. Yeah.
Okay. So maybe your population don't have as many folks with, but I think as you think about getting more specific around the chronic conditions is, focusing on particular medical conditions like the diabetics or the asthmatics or the heart failure folks. That probably going to be easier to impact that group. Yeah.
We're most specifically looking at diabetics.
Okay. I thought you were. From what I knew. So okay. Thanks. How about this table? Kate from?
Hi, I'm Kate with the Institute for Family Development. I have Christy and Danae as well, and so from the same agency. And so our target population is youth from birth to 21 years old who are on Home Builders or a WISE team.
Okay.
Those are the only two services we offer there. Who have the chronic conditions regarding mental health, usually, and possibly co-occurring issues, but we're focusing on mental health issues, and then within that population were youth who are on medication, who have either gone into the, like, an inpatient, who had like that transition from a care facility or an ER visit and have had med changes, and there's often, you know, confusion about what they should be taking and who did what, and for the parents to know too, like what are some side effects to look for and help manage kind of any side effects and symptomology that might come out of the med change.
So, you know, as you think about, this kind of gets back to the target population again, but as you get to create this registry, it sounds like, you know, of folks are being able to follow them proactively, is that you'll get into the questions of what are the inclusion criteria? What puts them on that list? What doesn't put them on the list? What puts them on maybe a parking lot list of folks? Or what puts people on, youth on another list? And it may get down to they've had one hospitalization, or they've had 3 visits to the emergency room in the last year, or there may be, you know, those are the kinds of specific things that you'll need to start thinking about and doing some work around in the planning process. Yeah. So, okay. So yes. So let's move on to the next element. Next element is around self-management support. And so what are the things that you could do in your organization around that targeted population that would help them, the client or the patient, whatever word you use, the individual, to help them self-manage their own chronic condition? What are the things? There are a number of tools out there and ideas. So just reflect on that individually, just for 60 seconds before you talk to anybody else. So no talking for 60 seconds. I know it's hard. And then we'll have you, again, share with your partner what you were thinking. Okay, now you can share.
Okay, well, there you go. There you go.
I don't think I've come over to this table over here yet. I'll be back to you guys. Well, okay. Okay, let's have somebody share something about self-management support. How about this table? Anybody here want to step up?
We're still gathering our thoughts.
Oh, that's okay. Share some of those thoughts with us.
We're curing obesity by introducing people to meth.
Oh, yeah. That's an age-old physician technique. So why don't you tell first about your targeted population or who you're.
We haven't nailed it down, but
okay,
we're looking at
that's
right
fine.
now sort of alcoholics that are diabetic.
Okay.
So if we can identify those folks who come through our door, that would be the population.
Mm-hmm.
And then we would provide, we do a BHT9 for us, and we would put that person on a registry. We would have a behavioral health coordinator make the connection. If they don't already have a doctor involved, then we would get that going. And then I think you said that we would want from the doctor the A1C information back from them, and then we would share information that we collect that would be beneficial to them as they're treating the same patient.
Okay, so let's bring it then back to the patient in terms of how. What are some ideas or things that you could do in your organization to help them understand and manage their own conditions? What are anything that you guys talked about with that?
We didn't really talk about it,
okay.
But I could imagine we'd have information on hand. I mean,
okay.
Yeah, and probably it would be our behavioral health coordinator that would do most of that work. Maybe it could be the therapists that are involved, but yeah, just education, just basic stuff.
Okay.
To help them get connected to the doctor, help them understand better, so maybe that connection can be made. I don't know.
I think one of our biggest fears is working outside our scope of practice. So when we're talking about the doctor will send an A1C and I get a number that says 9, it's like, well, I'll put that in the file. What does that even mean? And how we would be able to help a diabetic alcoholic educate themselves about diabetes management when that's not in our scope.
It's really the doctor's kind of what I was thinking
right.
too.
Sure. But how about in terms of how you might connect with other resources without going through the physician office?
Oh, certainly.
Yeah. So those are the kinds of things to think about. Okay. Well, what are ways in which the response isn't, oh, go see your PCP. All right. Instead, you have an alcoholic, someone with diabetes who is struggling with understanding or even taking their sugars. Well, is there what kind of connections do you have in the community with somebody that can get them there? Because if you make a referral, it's about a 50-50 at best. Maybe. What do you say, John? No. They're not going to happen. So this is kind of like the main idea here. It's like a main idea, is that you all can be part of the team with the PCPs and everybody else in the community to get people and help them manage and give them the skills and knowledge and motivation to do things. It doesn't take a referral from me for you to do that. Please go do it. Please go. You can go ahead and do it. So that's the point. So, and when you think about that I just soon have them get there. Yeah, John.
So, Ron, one of the things they might want to do, though, is
yeah, right.
So, and they know what they'll be told, and maybe we could work together. But they need food, and so is there a way to resource them through somebody with food that also says, hey, your A1C is 9, that's probably not as good as it should be. And maybe if we can pile on things that motivate them, that would be helpful.
Mm-hmm.
Great, thanks. Yeah. How about this group? Yes, Andrew.
Yeah, Andrew, ESD 101. So for our population, we're looking at K-12 students with behavioral health issues, and so we're kind of looking at two distinct populations in the sense that for our 13 and over, they can.
654, Tony.
I'm not the only one hearing that, right?
Yeah, that sounds like a hospital operator.
They can consent to services. So then a I think it's having that conversation directly with the client about, do you have any chronic illnesses? Do you have a PCP? When was the last time that you had a physical or saw a doctor? And really empowering that client to drive that, especially for those with diabetes or asthma or other chronic illnesses. And then for the younger population is providing that education and that connection with the family. And helping them, once again, to empower them. I think the idea of connecting them with resources such as food or transportation and housing, I think that's huge because that can really get buy-in as opposed to, well, you really need to see a doctor, or when was the last time that you saw a doctor? And then we've been talking about creating that formal relationship. We're in the process of exploring, trying to create that formal relationship with the CHAPS clinic so that it isn't just calling the PCP and saying, well, this is the information that we have, or doing that information flooding that someone mentioned where they're just going to briefly look over it and not be able to take any of it in. But then really making that connection with the clients and helping them drive services.
Great. So is anybody doing chronic disease self-management classes? Anybody have that on your list of things? Okay. Can you just say a little bit about why or what you're doing? There we go.
Blake Redding with Spokane Treatment and Recovery Services. So what we're talking about is early education and prevention classes, basically, for our withdrawal management and sobering diversion patients. Those are basically the patients that come in that present mostly with chronic hypertension, diabetes. So we partner with WSU and Gonzaga for nursing students to come in to teach about well-balanced diet, what it looks like to have hypertension, how your lifestyle can affect it. It's really early education stuff with resources and care plans for when they discharge. So it's really just kind of beating that in of how to prevent it, how to deal with it, and the lifestyle they're leading. If they're not taking care of it, it's going to lead to way more serious biomedical conditions.
Yeah. Great. The chronic disease self-management, I don't know how much folks know about this. Are there resources here in this community and for these classes? I mean, it's led by usually an RN nurse and then a lay person, usually sometimes somebody with the chronic condition. And it's a 12-week session of where they learn how to manage things, not just their condition, their medical condition, but they also begin to understand what to do when they're feeling depressed, when they're anxious, or when they get sick. What do I do? How do I garner resources to help with that? So it really gets to a lot of the emotional and behavioral pieces, and it's very helpful. I've had folks come back from the class that ended up meeting with this group over a long period of time. They started having meeting once a month, so it becomes a peer support kind of group. So I want you to think about that. So I think we ought to move through, and what I'd like to do is I'm going to jump down to community-based resources element. And there's a little bit of that discussion here, but thinking about what is it that you could be doing that helps your folks connect with some community-based resources or organizations in the work that you do. How, in particular, thinking about your targeted population, how might you help them access community-based resources? So just reflect for a little bit.
Yeah, so I mean, integration, you're right. It'd be great.
Bounced? So I think we're just in general kind of running 15. Let's hear from folks about how they think they could connect their clients and to community-based resources, thinking about it within the context of a chronic condition, targeted population that you'll be working with. What might you do in your organization to help make that happen? How about you guys? You have?
We're still struggling.
It's still struggling. Yeah, we know.
We pondered
Yeah.
Making proper and appropriate referrals.
There you go. All right, there you go.
we pondered making proper and appropriate referrals.
Okay, to who?
To whomever. To whom is appropriate, as needed for the client's care.
So how are you going to make that happen in your organization?
A secondary case management would also make that easier, because that, I think, in my mind, that would be someone that's more knowledgeable about who to refer to.
Okay, so and who would that be in your organization?
Nobody yet.
Who do you think it could be?
Nobody yet. It could be someone with a credential, a mental health credential, or a substance abuse credential.
And well, just tell us where you're from, so we know that. Okay.
New Horizon Care Centers.
Okay.
So in some of the questions that are asked, there seems, to me, this is how I interpret it, is there's some presumption that we have people sitting around with not much to do.
Mm-hmm.
You know, like who else could that be that could just pick this up and run with it? And that person doesn't exist.
Mm-hmm.
We are all wearing many, many hats in every place that we're at.
Yeah.
We're all busy, busy, busy. And then people say, well, let's figure out a low-cost way to do this. Who else can pick this up?
Yeah.
We don't know. We're trying to figure that out. It usually means adding someone and figuring out how that's going to be a billable service.
Yeah, that's a huge issue. You know, going and asking your staff to add one more thing to their day is like it's dead on arrival, right? It's not going to happen. And so this is true in the medical clinics as well. You just cannot ask people to do. And so a couple of thoughts about that, and some things that we actually were successful at. One was actually looking at our current processes. There's so much waste. About a third of what we do in our offices, in our practices, probably maybe more, is either to organize that and to look for that. But I highly involve the staff to help you with that, because most of the staff know where it's inefficient and ineffective. So to me, if I were to put something out there, that's what I would recommend, looking at it in that way. The other is to replace something. So we wouldn't add something new unless we got rid of something else. So that's another thing. Sometimes it's easier said than done, but again, sometimes the staff know this better than we do. But this is continuously a problem as to how do you find the time to do this. The other thing is that we, particularly when it comes to referring, using community-based resources, is that there are some ways in which you can invite other folks into your office or your practice to do some of that work. In our practice, we invited the Alzheimer's Association to actually set up shop once a week to help with families and with resources and referrals in the community for patients with cognitive impairment. So, thinking a little bit about some of these other methods could be helpful. How about let's go one more comment about this table. You guys have anything to share?
Using my voice is pretty.
Yeah. Where are you from? And
my name is BJ Snyder, and I work at Spokane Public Schools. And we are looking at connecting with Frontier Behavioral Health on 211. Do you want to share, Kelly, more about what 211 is?
You guys just keep passing the talking stick over here. We were just talking about 211 is putting a lot of effort this year into not just being a call-in Monday through Friday, 8 to 5, that we are beefing up our website. You can actually text 211 for resources. And one of the things we've been doing as we're out in the community is we're kind of giving material. One is for the professionals, information about explaining 211, what are the types of resources we can provide, how we can provide those, including now we complete basic food applications for people instead of referring them to that. And then how we can learn more about the agencies so that we are hopefully removing barriers when we refer people to one of your agencies. We kind of prep them, right? Like they do walk-ins, so you might want to go a little early or use the back for the wheelchair access, those type of things.
And then we're arming providers with handouts to give individuals so that they can contact 211 or get resources on their own, not just when they're in the office with the providers.
Great. One idea that some folks have done is most organizations have monthly team meetings or staff meetings, right? Is to set aside 5 or 10 minutes and invite one of your 211, the most common folks to come in and provide information so that everybody hears about that resource, and including any resources that they might be able to provide to the client. So that's something else you can sometimes add to the staff meeting. So our partners from primary care across the hallway came back, and so let's move toward, we didn't cover all of the elements for the behavioral health folks in here. We got through about half of them. But what I would say is I'm hoping that there were some other ideas that came up around some of the other elements that you'll write down. I know that a lot of folks are working on registries already. I know that clinical information systems is a huge piece that we could probably spend a long time talking about, and some of these issues are not solvable. And I think that's all I had to say about that. So let's move to a report from the folks across the hallway. And so, Anne, Charisse?
We'll co-team this, and I want to know who's running the show. Enough time to discuss.
Yeah, I don't know. Who's
Yeah,
running
I don't know. I don't know.
Who told me how much time you had?
I'll let you start, and then I'll try to read chicken scratch.
We likewise didn't get through. We talked about delivery system design inevitably leads into team composition. Who are you using to do what? How's that working? How are you going to pay for keeping that person on your staff, right? So some of the things we touched on is, in a big way for many in our room, is new and expanded rules for pharmacists. And definitely, in Washington State allows a pharmacist to work more independently than any other state in Wisconsin. We have this pipeline with pharmacists between Wisconsin and Washington. So if you haven't looked at how you might use that role, something to consider. New rules for RNs at all level, 2-year masters, but basically expanding that role into behavioral health or broader-based care management versus case management. Little different role. Won't get into the weeds that we talked about in the other room. Also, just some of the other education and licensures we were talking about, dietitians, and talking about a big value add there for the kind of group work and some self-management support, doing the food tours, having that monthly cooking class, etc., that not only engages clients in learning something about taking better care of themselves, but also gives them a social outlet that might be an important part of helping them stay healthy. So, we then also exchanged a lot of information about, and how are you building on that, and are you able to cover the cost of that with who you're using? I just want to say, in our room we had everyone, we heard about folks from medical assistants who are being trained and doing a great job in chronic care management, as well as licensed social workers and others.
Mm-hmm. So. You got it. That's all I got.
Okay. Anyone from my group, anything else to add particularly? We also traded information about how people were evaluating risk, which is useful, but I'll go into those weeds yet.
Okay.
Okay, thanks.
All right, so with that, we did promise we'd feed you.
Nope.
No? I thought you guys were, that's what you were doing.
No, we're waiting for everybody to get back in the room.
I got them excited for lunch, and now you're gonna, all right. Sorry about that.
You could be the first one in line.
Okay.
So, John, you want to reflect a little bit on what was
So a couple of things I heard, and we got through it all, Charisse, man, sorry, I mean, we did it like twice, and we got all the right answers, so sorry you didn't have enough time. One of the things that really was centered, I thought, was communication and transitions of care, is that people need to figure out how to communicate better, and one of the things that I heard a couple of times as navigators, we need navigators, and I think that's really true, that we don't know, and so this is good that we have you all in the room together talking about, well, these are the resources I have, and so part of that is to create a community of what are the resources. I agree with the pharmacy decision. Let's get everybody practicing at the top of their license. I think that's really what we want to do. One of the things that I also heard was that students were helpful. And I'm going to tell you, in this greater community, there are a ton of students from Eastern, WSU, UW, Gonzaga, Whitman, and so those are resources that could help. And they're young and they're eager and they're going to save the world. And so one way to take advantage of that is to figure out how can we get some of these people into our communities and working. And that's our greater community. So I would take that as a pearl that I'd walk away with and say, maybe we could get some interns here and figure this out. So it's communication, realizing the resources, and students.
Great. Anybody else from the group want to comment about the discussion? We spent a fair amount of time talking about the population, and it's a very it's so broad in this group in terms of both age, in terms of conditions, whether they're mental health conditions or physical conditions, but I think, and it's hard to think about how to stay focused. But I think this is an area where if you can focus on a medical and how you might integrate medical conditions, or at least recognize that there are medical conditions that you can play an integral part in helping them manage that. But also, well-managed chronic conditions can also greatly impact the mental health of the folks, and so it goes both ways. Okay. How about the phone? Anybody on the phone that wants to share work that you did in your space wherever you are?
We've got crickets.
We have crickets. Well, maybe the crickets will.
We've got a lot of the folks in the room who normally participate.
Nice. That's great. Any other questions for our panelists, or comments that you want to make before we break for lunch? What else? Anything else that you think you're going to need in this particular area that would help you to help put together at least for the folks that will be writing a plan for August, other kinds of resources of support to help you with that, thinking through this? Yes? Okay.
So that we know who we can access and point our clients to.
Okay. That may already be. Oh, sure. So the comment was to be great if there was a list of all of the organizations, maybe just amongst this group, but also in the community, that they could help point their clients to around helping them manage their chronic conditions. Are any of them what?
Mobile.
Mobile, meaning. Yeah, so that's likely true. I don't know specifically who they are, but I would think that in a lot of communities there may be a diabetes program, or at least a group of people that might meet and provide diabetes education. Certainly in the hospital, the nutritionists and other folks is a good way to use the local hospital resources for some of that. And we could also maybe identify folks that might be in the available in the smaller communities. Right? Yeah. Great comment. Any others? Okay. If not, so let's break for lunch. Go grab your lunch. The next part will be I'm going to talk a little bit about defining and framing complex care. So you'll likely be eating while I'm talking, but we also want you guys to get out of here in good time today. So we'll try to do both things. We'll take about 15 minutes, 15, 20 minutes, and I'll start.
Better. Even last month I was still struggling. I had about 2 months of walking pneumonia type of thing. Amazing. I'm sorry. That's probably I don't know what's bad. Oh yeah. I know, right? No, I had to get up. How are you doing? Great. Were you kind of thinking about chronic care in terms of behavioral health, or were you more into So are you, with, for that population, are you able to provide everything those patients or clients need, or are you trying to connect them?
So it's hard to think about a system where the information is digestible when you are doing it. You have a patient with something needs. I know what ACC is, but I don't know what the score range is. Diabetic 6 and alpha 3. So 6 implies like six different kind of like history of incarcerated or history of abuse. That's 6.
So I'm surprised they're not just signed up.
Impressed me about the primary care conversation was you have these different groups of totally different reimbursement structures. F3Cs, rural health centers, regular hospitals, each one of those reimbursement systems. Like, how are we going to coordinate when different people get paid different things? Your class, there's hospitals versus your unionized. You can't necessarily. Okay, now they're care coordinators.
And so, yeah, with that, I mean, more of
We are kind of been last year or so, like kind of created a whole department we call utilization and care managers. So it's got case managers, people focused on a small panel of really high needs, chronic disease patients who've been using the ER, and then care coordinators to kind of work with those folks, but maybe help more people just kind of access the right service. That's kind of centralized stuff, and then we're also trying to figure out RNs and 17 community health workers. Individual patients versus like looking at population list to more actively reach out to kind of figure that whole thing out. As we go. Oh, really? It's been hard to find like RNs. There's so much. Tried for years to try to figure out the role, but when you hire an RN, they're usually hospital-based, trained that way, so it's hard to shift that to RN. It used to be RNs were an outpatient all the time, but then MAs kind of replaced them. And now we're trying to bring it back in different ways.
We don't see a lot of this 65 or 75. I've been able to drill and use them and give each one a director. Ryan was just going to eat, sorry. Of all things, they're not profit. How's your mouth feel? Is it still numb? Oh, right. I know it's weird. You have to get self-conscious, don't you, when you're talking? Yeah. Yeah, exactly. The bib, just never mind the bib. Okay.
Crown in place next week. On Justice. Annoying when the hair starts to age out on you. Done with that thing.
He's retiring. Did you know that?
All right, I'm going to get started because I need to. I'm winning. Okay. So use the whiteboard.
halfway between my draw and downtown. I bought a fairly new house, moved back into my vacation. That's what I was talking about. Planting some trees, I looked at Google Maps a couple years ago. So I think it's huge.
And hate to interrupt some of your conversations. I was telling folks the networking piece is not. I do not underestimate the importance of being able to network with each other. A lot of times, and we just don't have time to, in our regular professional life, to have these kinds of or the time to have the conversations that you're having here today with folks. So I encourage you to continue to do that. Hate to squelch it, but please continue to have lunch. If I faint because of hypoglycemia, somebody will go grab a syringe of glucose and give it to me. But I'm fine. So I want to spend the next half hour, 45 minutes, talking about complex care and how to frame or how to think about complex care, because this is a term that's been used a lot, I'm sure. Folks hear about complex care, about high risk stratification, a new term that I'm going to introduce, maybe a new term, maybe not, called high need population. But I'm going to try to give you a framework to think about this. There's some really, I think, is pretty exciting work that's been done in the last few years around thinking about who this population is, what are the services that they need. And there are three major papers that I think one came out of the National Academy of Sciences recently. There's one from the Center for Healthcare Strategies and another from the Commonwealth Fund. And they're in your resources in the slides so that you can see them. And then there's going to be a fourth one on complex care in rural areas. And it's not out yet. I participated in this panel this past year. But I am going to share some of the key themes from that, so that you can kind of people are thinking and talking about complex care. We need to apply and we need to do. Hopefully, you all saw this quote. But this is sort of the one question: is you have a crowd, you have this group of people that come to see you. Who's the complex patient? Who is this person? And how do you sort them out from everybody else that's in your practice? And it's something that there's actually not a ton of literature about. There's lots of opinions about this, and there are different strategies that I'm going to share with you about the different strategies, ways in which you could look at a population and think about sorting out which are the ones you want to identify. But it quite literally comes down to your own organization, your clinic or whatever, of the population that you're really targeting, that you want to, that are unique, whether it's adolescents or children or adults with alcoholism or whoever. We're going to start with this. Blake, would you mind coming up? I mean, just kind of standing here.
No, I'm going to be a patient.
Yeah, you be a patient. Be a patient for me. Be patient with me.
I will.
Be patient with me, and then you can be a patient. You don't. Fortunately, you don't have to do anything. You can just stand here. So who is the complex patient? And I bring Blake up because of a case that might in practice where a young man, Blake is young, who came to my practice, about 35, moved in to become a manager of an auto parts store, but also had diabetes, and came to see me as a primary care doc. And because he needed his medicines, he moved up from Texas, and needed his medications refilled and to establish primary care in the community. And so that seems like that's something that I do, use usual history. And in my practice, I had a medical assistant, and actually I had a care coordinator. So I don't. Do you mind standing up? You could be a medical assistant, and somebody want to be a care coordinator. Oh, you're eating. Okay, somebody else. Anyway, so in my practice, you can stand up nearby. It's fine. So in terms of the care for Blake, really, his interactions were usually with my assistant or with maybe the care coordinator who has who came on the registry as one of our diabetic patients and would be responsible for making sure that he got his hemoglobin A1C a couple of times a year and urine tested, et cetera, et cetera. So this was kind of the team that would be appropriate for Blake. Are there any pharmacists in here? No. Who wants to be a pharmacist? David, you want to be a pharmacist? Okay, so David is a pharmacist in the community. My experience is that most folks like Blake or myself, I have a pharmacist in my community that I usually go and get my medications from and get to know and actually answer a lot of questions that I don't have to make an appointment for. I just point that out, particularly for folks with asthma and diabetes, that the pharmacist is a critical piece in the care in the community. In fact, you take states like North Carolina, where they've actually created a system where in a lot of the small communities, the pharmacist is sort of the main point person for people with diabetes in those communities, doing the education and so on. So I just want to kind of recognize that, but I want David to stay. So this is kind of the usual kind of care. So let's fast forward 10 years or 15 years. Unfortunately, Blake had a back injury.
Should I lay down on the ground?
Yeah, no, you can stay standing. That's fine. And unfortunately, it didn't go very well. Ended up with a surgery. Ended up with some chronic pain. The other thing that I didn't realize early on, and certainly as a clinician, my fault, is that actually Blake had a history of depression and had been on and off, but that hadn't really been bothering him at the time when he came to practice. But now he had been off work for a number of months. Unfortunately, he also became addicted to opiate pain medication. Unfortunately, was unable to, this is 10, 15 years, and had also hadn't been exercising, gained a lot of weight, and et cetera, and was not doing very well, but I hadn't really seen him in 6 months or a year because of this. He ended up losing his job, and it really actually ended up his spouse needed to go back to work and so on. But as it turned out, he had an injury that created a problem with neuropathy in his feet, and he had a diabetic ulcer on his foot. And so had him see a general surgeon. And who wants to be the general surgeon? You look like a surgeon to me. No? No? Yeah? No? No? Yeah, you can stand up. Yeah, so the general surgeon and his assistant became involved. Ended up going into the emergency room for a number of times. I think there's an emergency room physician right there. Mike, you wanted to stand up? And usually, you know, the physicians, there's usually a nurse or social worker there, so if somebody else from the table could stand up. They were also involved in a number of emergency room visits. Now, actually, part of his treatment was connecting with somebody in a therapy office nearby, referred for counseling and so on. And so, you want to be a therapist or for him? And in that particular office, they also had a care coordinator or a navigator. So, somebody else want to stand up there? There was a hospitalization and in which the foot ulcer got infected and ended up being hospitalized with the surgery. And there was the hospitalist right there. There we go. Jason will be the hospitalist. And then there was also a care navigator in the hospital that also got involved. How about the gentleman next to you? So there was a point here in which Jason's healthcare world looked like this. It looked, and there were probably, and that didn't even address the kind of the social issues that were going on at home and the management of things not going well at home. They're potentially losing their home, and they didn't have the money. Still didn't have SSI, and so had applied. And as you know, that takes a few years sometimes to get to that. But so in general, how do you think, if you looked at your overall health at this point, how do you think your health is? Do you think it's excellent, very good, fair, poor?
Poor.
Poor. Okay.
Very poor.
Yeah. So to me, this is kind of an illustration of what complex care looks like. We have folks from different facilities, from different disciplines. There's likely an eye ophthalmologist in there if he has a diabetic foot ulcer and other. There may even be a renal doc in there somewhere. There may be social services out in the community that are also involved at this point. So I just wanted to sort of illustrate, at least in my head, how this looks like, and then the idea that, well, how much do these folks know about who Blake is? So, thank you. So so what do we know about risk? So I want to define some terms for you that are out there. First of all, realize that risk really is talking about future spending. We're really talking about where the potential for future spending for physical, mental, and I would also add cognitive, functional decline as well. So that's really, you're looking at risk and trying to prevent something. High cost, really high cost folks are people who have already spent their money. Okay, the horses have already been out of the barn, and they've already had their heart attack and bypass surgery. They've already had their hip replaced. They've already had the high cost of their medical intervention. So that's I want you to understand the distinction. And then the third term is high need, and these are folks who might be both high risk and a high cost, but they're also in need of more intensive coordinated care. And how many folks have seen or used high need as a designation of folks? Okay, yeah, a few. So this is a term that's being used more and more about how we think about services and the services that we provide. So let's look at some data. There are three ways that I want to share with you in which we tend to look at high needs and separating out, finding those folks in that crowd that we need to be paying attention to. First of all, if you look at national data, 1% of the people who spend healthcare dollars account for more than 20% of all healthcare spending, 1% for 20. The top 5% accounts for half of all healthcare dollars. And the top 10% account for 2/3 of the dollars. This could be different in different regions, organizations, but in general has been true. And that this bottom third, the bottom 3%, or 50%, the half of the people who are out there, really only spend about 3% of our healthcare dollars. But this doesn't tell the story, right? This only tells the story of people who have already been spending the money. And if you look at the top 1%, about 46% of them, 46 to 50% of those folks, about half, continue to be high spenders for the next 2 years. So the other half sort of fall off because they'd already spent their money. And that about 1/3 of the folks in that 1% are episodic spenders. So they'll spend a lot of money in the first, for 2 months, then there may not be any spending of healthcare dollars for months or a year, and then they come back and there's more episodic spending for that. So this is, people look at cost as a way, as a proxy for determining who they should pay attention to, but it misses people, misses a lot of folks. In this state, using the PRISM scores, and I know there are people in here that are probably experts in the PRISM scores. How many people are using PRISMs or know this here? Okay. Oh, okay. Yes, you want to repeat that? So unless you're health home enrolled, providers won't see this information. Is that correct?
Can't get access to PRISM.
You cannot get access to it. So we pulled some numbers for the state around PRISM. So PRISM is you can read there and you can go back and look at this, but it's a Medicaid risk score that's calibrated to the state's Medicaid disabled population. So you have a disabled population that costs so much. Everybody else is compared to them, okay? And it's a ratio. So so a score of, it says there, of 0.5 would be somebody had a score of 0.5, then they're at 1/2 to the reference population, which is the disabled population. That's 1.0. If they have a number over that, that means they're going to spend more money than that population. So I am not an expert in the PRISM scores. I've learned a lot about it since working up here. Anne, you know much? Or?
Well, we talked about this a little bit in our primary.
Okay.
I actually, when we rolled out PRISM, I assigned about the first 5,000 patients of home providers.
Okay.
My experience with PRISM was that there's a certain number of very high-cost patients that show up and get assigned to health homes, and there's almost nothing you can do to help to lower those costs or improve that cost.
Yeah.
Maybe, but they're just way high.
Yeah. The horses are out of the barn.
So you have to be able to sort those out and look at why they end up in PRISM.
Yeah.
Is it because of ED visits or what? So if you can't get into the weeds, you can't use PRISM very well.
Right. I showed this slide because I wanted to show you that they're using, there's a certain sense in this state, using PRISM scores as a sort of another kind of financial or spending way to define risk. Or high cost. A couple of things I would just point out is just that in terms of the average for the state and the average for BHT in general is higher in BHT. The other is that your disabled group, if you compared your disabled group in BHT with the disabled group of the statewide average, it would be 0.32 more spending in this region than the statewide average. And same, again, the other big group is in the elders. That's likely a Medicaid dual eligible folks, I would assume that's where they're using this. I just point this out as this is another tool as a way to look at high cost or cost using finances as a way to screen and to distinguish folks. I put this slide up here because a lot of folks have talked about 3+ emergency room visits as another way. And so using utilization data might be a way, is also a way in which people think about how to separate folks out. I know that in pre-manage, you can get some of this data from about ED use, and so you might use that as a way to identify folks to target for services around care management services or other services using utilization data like a 3+ emergency room visits. And when you look at BHT, it's the same, virtually the same rate as it is in the state. I'm not saying that that's good or bad. So the other way to think about sort of separating out folks is looking at chronic conditions. Is there a way in which you can, are there certain chronic conditions that put people into a category of risk or high cost that would separate it out from everyone else? This was a study that was done through the Commonwealth Fund a couple of years ago to look at what are the most likely diagnoses that led to higher morbidity and cost. Okay, they looked at all the chronic conditions. Okay, what are and then so they divided them out. There were 9 of them that that floated to the top. It said these were the ones that really were caused most morbidity and most cost. And you can see that it's certainly ischemic heart disease, the chronic kidney disease, dementia, psychiatric disease, stroke, and diabetes. The others, it's not that there aren't some very high spending folks that have lupus or that have disabling neuromuscular diseases. I mean, you're going to have folks in those categories as well, but it's likely maybe be screening. They might make it over onto the list in a different way other than just their diagnosis. But this is another way in which folks will think about identifying high need. And then probably the most basic way to identify folks with high need is through activities of daily living, is through function. I just put these up here as the sort of the typical activities that you can use to identify folks that might make that list. And what's interesting here, and I'll show you, this came out of the Commonwealth Fund recently. So the first, this is the total adult population here of spending. This is the median right here, top 25%, and this is spending per year. And then this is the top 10%, 5%, and the top 1%. If you only have, in the group that had 3 or more chronic diseases, but no functional limitations, just chronic disease, you can see that it went up appreciably in all of these consistently. But if you have 3 or more chronic diseases and you add functional limitations, look what happens to spending. So beginning to look at how cost and physical function and physicality relates to this is actually important. And thinking about that. So this group that recently finished meeting this probably about 6 months ago, they've published a book. You can see it, the citation is down here. It was looked at what were the sort of the characteristics of the high need population. This was drawn from what was out there in the literature, expert consensus about the list. So I wanted to show this to you. It's generally an older population, female, Caucasian, less educated. They're more likely to be publicly funded for their health care. 83% of them were either Medicaid, Medicare, or dual eligible. So self-reported fair or poor health. Poor Blake, I set him up for that question, okay? That's why I asked him that question. In general, overall, what do you think your health is? And people who and we've known this in geriatrics for a very long time, for a couple decades or longer, if they respond to fair or poor, then they actually move into a category that's a higher risk of functional decline. Behavioral or substance abuse conditions fall into the list. Functional limitations, we talked about that. And the last thing, I added this because there was a reason why we added pay for achievement for making sure somebody has a primary care clinician or a healthcare site. Is that only 46% of the folks in the high need population reported that they had a usual source of care. It should be 100%, right? I'm just going to stop. Any questions about that? I shared a lot of kind of, all right, it's lunch. Getting the postprandial nap in. Yeah, sure.
How do you, I'm kind of step back on the slide where you were talking about complex versus chronic.
Yeah.
Where did that information come from? Is that just based on numbers and where the spending is going? Because
Yes.
So we're talking about complex and high needs clients, and generally a lot of those clients, probably by number, also include mental health, behavioral health, or substance use.
Yes.
Yet I didn't see any of those on the list.
Psychiatric disease. I mean,
that whole spectrum.
Yeah.
Okay, and then substance use. Okay, that's really interesting.
Right.
Because a lot of times you'll find people that
Absolutely, and that's why we're in this room, is exactly that. That's exactly right. No, that's why you can't just look at this separately from everything else. It all goes, for the diabetic, how their emotional state is and behavioral state impacts how their diabetes is controlled. How their diabetes is controlled is going to impact how their mental and behavioral health is. So, yeah.
Okay, so in this context, in this room, all of that would fall under psychiatric disease.
Yeah, I'd have to look at the data, but I think they probably just lumped it all into that, yeah. So this is a slide that talks a little bit, they talked about these special circumstances where folks are more at higher risk of needing more help, more coordination, more collaboration. There are some special situations. And so these are 1, 2, 3, 4, 5, 6 of them. One is anytime you have a surgery or an acute injury like a car accident or a fall, you break something. Those are things in which something physically happened, but it has a mental and emotional stress to it. Intensive therapeutic interventions. When we're talking about here, this could be the cancer patient going through chemotherapy. It could be one of your clients in the psychiatric unit in the hospital who has had who is needing intensive interventions. Those folks should be followed closely. You should know about them within 24 hours of coming out of there, right? If you don't already. There's a system, they fall onto those acute events. Chronic addiction-related impairments are folks that need to be between the physical and mental. Long-term cognitive impairment, certainly the dementias. Long-term mobility impairment. Someone with a stroke who no longer can walk, who had previously been running 3 miles every other day, okay? There's a change, and then, of course, the end of life, and sometimes we don't put that, and that can be at any age, right? So these are special circumstances where you might think about being triggers for you in terms of thinking of how you separate out those folks in that population. Again, this was consensus-driven. There was some literature about that, but this is very early on, and in many ways, I'm thinking this is has potential of being something that could have, like the chronic care model, could be a model or a taxonomy for how do you think about high need patients. Because you have this large population, it's heterogeneous. In other words, it's just not one group of people. They fall into different categories. You don't want too many categories, right? But you want enough categories where you can design a plan in your practice that addresses those folks in a meaningful way, and also a way in which you can test some of these things that you're going to do. So what they did is they created a taxonomy for high need patients, and number one is really looking at it from the clinical and functional groups. This is totally looking at it from my clinical lens, folks, okay? I know there are folks out there in the behavioral health world are saying, well, you know, I'm not sure this really fits for me, and that's not, you know, you would have a different set of lens, and that's where I have to give it to them, the National Academy of Science. They recognize that. They recognize that across all of those, that there are behavioral health factors and there are social risk factors. And this is the part where I forgot to put the slide in. And I'm going to tell you what the consensus is around there are 4 in each of the social risk factors and behavioral health factors that they came up with. So I think you might, what do I do with my, we'll grab one of these. Hopefully it won't be a permanent marker. We'll use blue. So for behavioral, yeah, I can roll it out here. Oh, the problem is that they can't project it. Yeah, they can't. Is this good? Yeah. So, there were 4 of them. One was substance abuse. So what are the sort of the key components of that actually go across all of those all of the others, right? So substance abuse. Second one is severe mental illness. Cognitive decline. My children can't read because they're 20, 30-somethings. They can't read my cursive. So I attribute that to my mother, who was a school teacher. And then the last one was chronic toxic stress as sort of the key buckets. So chronic toxic stress. People know kind of what I'm talking about here? What's that? Yes, okay. All right, so we're talking about PTSD. We're talking about ACE. We're talking about, what are the others? Anyway, folks that have ongoing trauma, have had ongoing trauma in their lives. But these are the 4 areas in which they felt were other buckets that you ought to think about when you're separating people out. So on the social side, what are those sort of buckets? So one is low socioeconomic status, poverty, okay? Second one was social isolation. Some people choose to be social isolated, other people choose to live out in the woods, okay? But that has an impact in terms of a risk factor in terms of their access and their access to care and everything else. So the third one is community deprivation. Okay. So community deprivation is sort of related to social isolation, although community deprivation is where your census tract, where you live. We talked about that last time around the social determinants of health, that one of the best predictors of your outcome is where you live. And the census tract that you live in, if you have a pharmacy that's is 30 miles away, well, that could be a problem for people, and you don't have a car. I had a diabetic patient in my practice who didn't have a car, worked in a 7-Eleven, had never been in a grocery store. She had bought all of her food at the 7-Eleven store. Didn't realize that until about 3 or 4 months and about 50 units more of insulin. Did we realize that maybe diet was the problem, and that isolation and where she lived was actually was a problem. So that gets into that part. And then, not surprisingly, housing insecurity. I went to, yesterday, as a matter of fact, went to Habitat for Humanity breakfast that folks spoke about the importance of Habitat for Humanity and having a home. But the thing that struck me the most is about this, and you guys probably all know this, but it was like, okay, is how that impacts their children. And their children in terms of breaking the cycle of home, having their own home, and buying a home, and having and the importance of home. But housing insecurity, I think, is a critical piece. So anyway, I wanted to add that, and it's just a way of thinking about how high need patients. So I'm going to talk just a little bit about risk stratification. I believe this is a critical first step. When you're doing this work, and because in care management to risk stratify. And really the first thing that you need to think about is how you build your services around how you're going to provide services to the population you're dealing with. And the two ways in which I think that you need to look at is, first of all, looking at longitudinal care management. In other words, identifying those that are at highest risk and would benefit for longer term resources. You may see them after a hospitalization for several times for a month, but then they end up being on your list because they're at risk, even though you may not see them for maybe every 3 or 4 months or a year. But sort of more of a longer term or longitudinal care management. And then the second are services and designing services around episodic care management. Knowing that there are going to be some of the same folks are going to end up in the hospital, but there are also going to be new folks that you've been seeing for a variety of reasons that all of a sudden have a stroke, or people that had an accident or a traumatic experience that suddenly you need to know and follow up with them probably within 24 to 48 hours, or within 72 hours if it's a hospitalization frequently. But these are, having a system in place that really addresses both kind of the longitudinal, but also somebody that's in charge that can look at the acute events that require some case management processes. So to me, you need a method for going through and figuring this out. We've talked a little bit about some of the risk factors and some of the ways of determining this, but I really think about this in terms of a two-step process. First is to decide whether this is going to be on diagnosis, is this going to be on cost, is there some algorithm out there? There are algorithms. I think this is the way it's going to go in the future. There's likely going to be biomarkers. There are going to be a number of things that people are going to put into an algorithm, and that's going to it's going to spit out a list of names that should be on your list. And then the second step is to bring it to your providers or your clinicians and have them and test it, and to have a conversation about, or your care team in general, about their perception of that. And so really that two-step process, this is a process that's being used nationally now in the Comprehensive Primary Care Initiative in terms of how you take a panel of folks and you begin to stratify them in terms of these are the ones that really fall into the list of folks that I need to pay attention to. And these are the services that I need to provide for them. And these are folks, yeah, they're important, we need to keep them, but it may be once a year, okay, or some other way. There are two resources down here. One is the care management implications for medical practice, the AHRQ, and then the other is the American Academy of Family Physicians care management tool. And this is actually a tool that they used for risk stratifying a panel. So you can just take a look at that. Anne, you want to make some comments?
I have a question.
Yeah.
Because I know I've heard from some of you here that you don't have much access to data to help do this, or at least it's not systematic.
Yeah.
So I just thought, could you say more about how you would stratify and diagnosis? Because we've looked at, complex, non-complex diagnoses, but I also heard some folks who were saying they were at this point stratifying based
Yeah.
conditions. And, any thoughts on what's the best way to do that?
I mean, I have a bias. I told you that at the beginning. My bias is to focus on a particular population, like a diagnosis, like diabetes, initially, on a specific Yeah, I think you could also, I suppose you could look at the number, but I just showed you previously, the number can only take you so far. It may not be, it depends on what you're trying to accomplish. If you're trying to reduce costs and utilization, I'm not sure necessarily number of chronic conditions is going to do it, because the one slide I showed you is that 2/3 of people over 65 are going to have 2 or more chronic conditions. Well, that's a lot of people, right? So I think that there are certain chronic conditions that provide risk that are important. So that's what I would say about that. And I think diabetes and asthma, particularly in children, you should know, if you're taking care of children, you should know which kids have asthma, because how they are mentally, behaviorally, it's going to impact that, and vice versa. So again, those are kind of easier things. You can use claims, so folks can look and see. You may have a claims database in your own practice. I don't know what you might say, number of phone calls, number of contacts or something like that. All of a sudden, it doesn't always mean the squeaky wheel, isn't always the best way of doing it, but it might produce a trigger for you to kind of go and look and see, well, why are they calling, 5 times a week? What is it that's not going well in their life that we need to provide a service for them? We need to have our care navigator or care manager call them and find out what's going on. So that might be it. And then there are some algorithms in place. I can tell you that in the practice I was in, we started actually with number 2 and went to 1. So I went around to had 5 clinicians and partners, and we put down our top 10. And then we went back and looked at them to determine which of these people did we need to have our care coordinator or care manager contact them. And then we started looking at kind of their utilization was probably the other thing. We didn't have any data around costs. That's kind of the upper folks, the managers and folks. All right, is this helpful at all to kind of think about it? Okay. So I'm running out of time here, so I'm just going to, most of these things are all things that you already know about, that we've talked about today, the importance of having the care coordinator or navigator as a communication hub and leader to help. Somebody's got to be in charge. Somebody's got to know all the things. We saw Blake. all these people. Who's going to keep track of that? Is that going to be me? I'm seeing, 25 or 30 people that day. It's hard to keep track of all of that. I need somebody else to help with that. So what kind of system is in place to make that happen? The coordination, there's some really good work that's been done with navigators or care coordinators that are called health resiliency workers. That have shown significant decreases in ED utilization, ambulance use. They actually brought in the 911 group to actually go, and most of them are actually master's prepared folks that go to high utilizers. So these are people that have 30 ED visits in a year. And there are those folks out there. I just want to point out the other part of this is medication management. We haven't talked a lot about it. I'm glad that Ann brought that up here today in the group across the hall. And we talked about having David be our pharmacist for a day here. But the importance of medication management and bringing that into us, it's a huge risk factor. People end up in the hospital when the medicines get screwed up, or the surgeon changes the medication. I don't know about that. They're calling the care manager here, who has a different medication list than the surgeon, then the emergency department doesn't know anything about it because they don't connect to it. So you can see it's a mess, right? It's not just complex, it's complicated. And so a lot of this is around communication, and medication becomes sort of the vehicle in which bad things happen to people, okay? So I am just really quickly to end up my time with you here is just talk a little bit about rural high need, high cost patients, some key themes that have come out of some work in the last couple of years. And there are two references here. One is a case study actually in your neighbors in Montana. I'm trying to think, I think they're in Kalispell. But you might think about taking a look at that, what they've been doing in rural areas to help identify high-need folks and provide them services in very creative ways. And then this complex care at the Center for Healthcare Strategies. But so one theme is that the rural social determinants of health. And certainly we know that transportation is huge. And the isolation, lack of publicly financed services, including housing in areas really makes this. And I'm not going to give you any solutions here. I can just tell you what the themes are in this discussion group. And again, they're barely scratching the surface in terms of, well, what really works? How do we address this? In this particular one, this is where telehealth could be of great help, particularly bringing in services that you might not have in the community but might be located here in Spokane that you might utilize that. Also local volunteer networks. They could be faith-based, they could be veterans groups. I think actually that's what they used in Montana, where it's actually through a VA outpatient clinic, some services, some networks for volunteers. The second theme is that rural healthcare is workers, how do you attract them? And we're not just talking about medical students here. We're talking about behavioral health specialists. We're talking about nursing. We're talking about community health workers, navigators, other pharmacists, others who there's a shortage, and then how do you get them to these areas? That's why the other group that so community health workers is something, a solution that's been used and thought about in large part because there are a number of people in rural areas that might be trained to do something else, but they're not maybe employed doing that, but this may be a training opportunity for folks that could be a community health worker, an outreach worker in these communities. The other is the paramedics. I know that's certainly a big thing that's happening in Oregon. So I assume that in Washington the same thing is happening with the paramedic organization. Social life of rural communities, there's a different culture there. There's this sort of this independence. I grew up on a farm, so I know about being independent and being a long ways from medical services. And the reluctance for self-help, reluctance for health, and a little bit of maybe hesitancy about whether you really trust folks coming in or not, and what they're really trying to do for you. So privacy, and how do you get beyond that and provide services in a community just because of the kind of people that are drawn to those communities. Adopting technology is a big theme. Is there enough broadband capacity to do all these telehealth things and everything that we want to do out there? So that's part of it. I talked a little bit about ECHO. And then finally, adopting payment methods to support this. That you really need to have that the resources and the services that might be available here in Spokane are really not going to be available or even affordable because you can't, it's a small number of people, yet they still need those services. But it's a small number of people and it's hard to build an infrastructure that costs to support that. And so how do you make that happen? And that some of these interventions cost money. And you want some of these interventions, you want some healthy people in the pool as well as people that aren't as healthy. And so it's hard for people to invest in those communities. So that really, and I left some resources for you. It kind of ends my sort of discussion here with you to share about what complex care, high needs population, how you might think about them in your own organization. It is very much contextual. You know who your population is. You need to think about, well, we really need to focus on the high need folks These are the people that to me, it's a canary in the coal mine. If you can take care of those folks, other people are going to get the right services. They're also going to get good care. So I think it's really a critical piece. I'm going to open it up for questions or comments at this point. Yes. Okay.
As you go through some of the specialty things, one thing I kind of noticed.
Get my steps in today.
That's good.
Yeah.
Is that you'll get your heart rate up too?
It does.
One thing I noticed today, for some reason, is you were talking about the mental health, physical health, kind of the well-being, and I just happened to think physical therapist.
Yeah.
You know, people coming out of surgery and things. That's not on any of these lists ever.
Mm-hmm. Yeah. No, another, I think, important team member.
Yeah.
Yep. And engaging them in that. And they can also be, they usually spend, I don't know if you guys gone to a PT in pain management, gone to a PT, but they spend a fair amount of time with you, right? They kind of get to know you. And so they could also be a great, another set of eyes for helping with this. Yeah, great. Other comments? Okay, Sharice, take her home.
Okay, super, thank you. Okay, so great discussion today, and it probably got you thinking about what is your next step as an organization. And so you walk away from here, you go home, you go back to the office, and what are you going to do? Talking to some of you who have repeatedly asked me if the slides are going to be available.
Yes.
Tells me you are not going to our website. So Better Health Together Learning Cohort website, I'll get to you in a second, Dave. Again, my school superintendent from high school. Yeah. Yeah. It's 2 degrees, it's not even 6 degrees of Kevin Bacon, it's 2 degrees of Sharice Pope in Spokane. So please go to our Learning Cohort website, all of the recordings, all of the slides, all of the materials. We even add additional resources. We've got the pre-manage EDI resource we're going to throw on there today. So they're not available before our cohort, they are available after our cohort. And Sarah is so phenomenal, they're already there. So please go to our website and see if the information's there you need. If you're still thinking, well, I need XYZ, we have on that same website a form where you can request technical assistance, the TA bank. That is free. I'm not kidding you. Some of you have used it, not a lot of you, but it is available. And you get to work with Anne when she comes to your house, is what I'm hearing. She's going to someone's house this afternoon. So it is available, and please utilize that service. We also have, coming up through the summer, a couple of opportunities that we're calling Lunch and Learns. So we're going to provide you guys lunch, because you seem to like it, and we're going to invite your colleagues to come and present around a topic. So you're hearing it colleague to colleague. You can ask them questions, lessons learned, how'd you do it, what are you still trying to overcome? And in July, we actually have Providence, who's going to come and talk about their collaborative care billing. They are going to share how they're doing it, what they've done, what lessons they learned, gaps, all those good things. Free. You don't have to come if you don't want to. It's not required, but you get lunch. It's an hour and a half. It's your colleagues. It's an opportunity to ask questions, okay? So we're going to be doing a number of those through the summer, but I think that one's probably going to be our first step. Next month for May, just teeing you guys up, our learning cohort's going to be around patient engagement, which is something that when we ask for your feedback, that comes back repeatedly. We want some technical assistance and support around patient engagement. And then June will be for our August cohorts. We're going to be working through our final plan, transformation plan, really centered around aim statements, milestones, and getting you guys ready to contract with us. So all that being said, you have, as always, your orange-ish survey on your table. It's underneath your packet. Encourage you to fill that out, please. If something didn't go well for you and you score low, I get that. But please tell us why. It doesn't help if something didn't go well for you and you don't tell us. We can't do anything about that. So please do that. And again, all parking feedback I just love to death. So I make sure you get that down there. I want to say one last, and then I'll let you guys go. But I want to say one last thank you to Dr. Stock and Ann Shields, Dr. John McCarthy, and Christina Wager, and Jason from Sunshine. Wonderful folks. Thank you all so much. It's always great to see you and have you. And please fill out your surveys and have a wonderful afternoon. Thank you. Yes, Dave.
That one showed money spent here.